Well, good morning, everyone. If I could ask those standing just to take your seats when you're ready, that would be great. Well, it looks like there's sufficient caffeination, which is awesome. Okay. Well, look, welcome to the 2023 Nurse Immunisation Conference. It gives me great pleasure. Would you please welcome Uncle Rick RC to deliver our welcome to country.
Morning, everybody. Nice to see a lot of faces here. I'm just going to do the welcome in Wiradjuri. Yiridumarang, Yundu Rick, Baladu Giramo, Wiradjuri Gibi, Nadu Banigu, Guambana, Ninyaugi, Nangiragu, Wiradjuri Garai Mojigali, Nurumbanga, Nadu Banigu, Nuna, Yinjamaragu, Mojigang Galang, Mado, Yalagiri, Mandangu, Wurugabinyagu. What I said is, hello, my name is Rick. I'm a proud Wiradjuri man. I'd like to welcome you all to this event on Wiradjuri land, God's country. I'd like to give my respects to the elders past, present and future. Thank you for listening. Enjoy your day. Thank you.
Thank you, Uncle Rick. Please welcome Brad Porter, Chief Operating Officer, the Western New South Wales Primary Health Network, to deliver our opening address.
Thanks, Brenton, and thanks, Uncle Rick, for the welcome. I too would like to begin today by respectfully acknowledging Aboriginal and Torres Strait Island people as the traditional custodians of the nations and the country on which we work and live, and commit to building relationships, respect and opportunities with all Aboriginal peoples in our region. We pay our respects to the elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples here today. Well, welcome and thank you. Thank you for taking the time to be here today. It is my pleasure and privilege to be here with you. On behalf of the Western New South Wales Primary Health Network, and in conjunction with Western New South Wales Local Health District and the National Centre for Immunisation Research and Surveillance, we welcome you all to this year's Nurses Immunisation Conference. We thank our partners and presenters also for being here today. We are lucky to have Professor Nick Wood, who leads the New South Wales Immunisation Specialist Service, Priscilla Stanley, the Director of Public Health at Western New South Wales Local Health District, and a wonderful array of other presenters that our MC Brenton will introduce to you shortly. I would also like to thank GSK, Pfizer, Seqirus and the Orange Ex-Services Club for their support of this event today. We know that immunisation saves lives. It is a global health and development success story, and we have seen this firsthand during the COVID-19 pandemic over the last few years. Vaccines save millions of lives each year and reduce the risk of acquiring diseases by working with our body's natural defence to build protection. In primary healthcare, immunisation is a key component and an indisputable human right. Immunisation currently prevents 3.5 to 5 million deaths a year. Vaccines underpin our global health security and are critical to the prevention and control of infectious diseases. The National Immunisation Program from the NCIRS has now been running for 26 years, with significant expansion since its inception, gaining national and international recognition for making key contributions in areas of immunisation coverage, vaccine safety monitoring, and communications about immunisation. In these years, we have seen immunisation rates climb substantially across Australia, and particularly in Western and Far Western regions of New South Wales. In Australia, we are lucky to have high vaccination rates, which in children of 5 years old, as at the end of last year, the national coverage was 94.27%. This number climbs when we look at our Western and Far West New South Wales region, with numbers of 96.77% for children aged 5 years. These are outstanding results, and I would like to congratulate you all for this. This is just a smidgen lower than last year. However, we remain the top performing PHN catchment across Australia. We will hear about our region statistics in more detail shortly from our LHD Public Health Unit. But in short, I wanted to offer my congratulations to you all for these outstanding results, which were achieved through continuous dedication, hard work, efforts, and collaboration by all immunisation providers, Aboriginal Health Services, the local health district, community health organisations, and general practice, for your continuous contribution to protecting our children and our people to preventable diseases. It is a real testament to you all here and all the dedicated healthcare professionals who show up each and every day to keep our people and our community safe, healthy, and as protected as possible. We know that the last year has not been without its challenges. We have battled with scepticism and have worked hard to change the narrative and ensure we always provide accurate information from trusted sources. Further, in the last year alone, our region has experienced devastating floods, bushfires, new variations, and viruses such as Japanese encephalitis and Ross River virus, and the impacts that resulted, such as power outages, cutting out storage fridges, workforce and staffing issues, the destruction of properties and businesses, and rising costs. And through adversity, we continue to come together, work together, and dedicate ourselves to the improvement of health in our region. I would like to take a minute to give a mention to our incredible nurses. We celebrated International Nurses Day on Friday, the 12th of May, the 203rd birthday of Florence Nightingale, British nurse and social reformer, who pioneered modern nursing. We hope the work we do will always echo the motivations of healing and commitment to servicing the needs of our people and communities. Western New South Wales Primary Health Network is here to support you in our collaborative efforts with our partners and stakeholders as we continue to build trust in our health system, share trusted information, break down barriers for our most vulnerable residents and communities, and continue to lead by example for others in our communities and other regions to aspire to. Congratulations to you all. This work you do makes a difference. It has an impact and it changes people's lives. We are grateful to share this day with you and hope you enjoy spending the day together networking, sharing stories and supporting each other. Welcome and thank you.
Well, thank you, Brad. And of course, thank you to my PHN colleagues for asking me to be the MC today at this nurse conference. As a Senior Digital Health Officer at the PHN, this is my first nurse immunisation conference, and I was very grateful for the invite. Michelle Duralis did secretly tell me behind the scenes it was because of my dad jokes, or the so-called radio voice, but I'll let you be the judge of that. But look, before I get into, I'd like to get into some housekeeping and just introduce some of the speakers for today. So the Western New South Wales Primary Health Network, Western New South Wales Local Health District, and National Centre for Immunisation Research and Surveillance are delighted to continue our strong partnership to deliver this year's Nurse Immunisation Conference. So we welcome a great lineup of presenters to deliver today's program. A local context will be provided by the Western New South Wales Local Health District and Public Health Unit team, including Priscilla Stanley, Belinda Tracy, Kendal, Wendy Holmes, Alice Gordon, and Kim Rice. As always, we are thrilled to welcome back Professor Nick Wood from the National Centre for Immunisation Research and Surveillance. Now, Nick has contributed to our program for a number of years now, and we appreciate his continued commitment to share his expertise and with health professionals working in rural and remote areas. Please find the program and detailed presenter bios on your table to share. We would also like to take this opportunity to acknowledge and thank the conference sponsors for today, including Pfizer, GlaxoSmithKline, and C-Cell Seqirus, and warmly welcome their representatives today. So please visit their displays at the back of the hall there, during the breaks and at the end of the day. So just quickly some housekeeping before we move on. For the facilities and bathrooms, just to my right here in the door in which you entered, there's some bathrooms directly to your left, snaking to the right, and there are also some at the far end here as well. Emergency exits are off to my left at here. Now, in the event, unlikely event, I hope, of a fire and the fire alarm does go off, we've been instructed to wait for staff to direct us in the appropriate escapes. If I could ask also just for mobile phones to be on mute throughout today's presentations. For breaks, morning tea is at 10:25 a.m. and lunch at 12:15 if we're running on time. Now for morning tea, there are some coffee stations. I understand there's the one immediately here near the exit doors here, but there's some further food and coffee into the greenhouse areas there if you haven't noticed. Now Slido will be in action today to help us navigate audience questions, so I encourage you all to please direct them through that mobile app. Now you can please scan the Slido QR image and enter the code 3241398 on your program. So visit the Audience Q&A tab to enter questions after each presentation. You can also like other questions to elevate their priority in the question queue. Now, questions will be collated and presented during the Q&A sessions. If all questions cannot be answered in the given time frame, we'll take them on notice and share the answers post the conference. You can also raise your hand and wait for the microphone to ask a question. My understanding is I think we have a couple of roaming mics on hand as well. And of course, this conference is being recorded today. I think you can give a wave at the back there. Okay. So it gives me great pleasure to now welcome our first speaker. Please welcome Priscilla Stanley, Director of Public Health, Western New South Wales Local Health District, to present a local immunisation coverage rates and public health unit update. Thank you.
That's how I drive.
That's how you drive.
Excellent, thank you. Wow, welcome back everyone. A few familiar faces, probably some new faces. What a great opportunity for all of us to meet again and share knowledge and experiences. I do only have 15 minutes, so I'll probably have to speed through, and I have something very well prepared, but I tend to go a little off script every now and again. Firstly, Priscilla Stanley from the Public Health Unit. I would like to thank the PHN for today, for organising the conference, and obviously the sponsors who are also part of today, and the other speakers. So we have our rock star, Nick. He is, I don't think Nick's here yet, is he? Not yet. Okay, we'll know when he comes. I'm sure you're all very much like me, where he is just a wealth of knowledge and a wonderful human being. But we also have our rock stars in the Public Health Unit, so you're going to hear lots from them today, really drill down into some of the programs that we oversee in the Public Health Unit. But this is a room with lots of experience in it, and I thought I'd just start by, as I said, going off script. For people to put up their hand if they've had more than 50 years experience in immunisation. Okay, that was ambitious, wasn't it? What about 40? Got any 40s? Yeah! Okay, so we know where to go for those that have got lots of experience. 30? Okay, hey Sue. Cool. What was I up to? 20. Here come most of the hands. 10? Are there any less, 5 or under? Ah, wow, the newbies. Any less than 12 months? A few, yay! Well, welcome. Is this your first conference? Fantastic. Well, I'm sure as your colleagues have hopefully talked to you and passed on what a wonderful couple of days. It's a couple of days for us, but day for you. So we'll start with, that's me. This is what we'll cover off as best I can. But I do want to start by saying it's a real honour for me to stand before you as the Director of the Public Health Unit at Western New South Wales and Far West, a local health district. I do truly want to express my appreciation to all the health professionals in this room who work tirelessly to protect and promote the health of our communities. And that I just want to repeat over and over again. Please understand the enormous amount of work you do protecting individuals that in turn protects our entire communities day in and day out. It does not go unnoticed. So today we gather here to enhance our knowledge, share our experiences and strengthen our commitment to providing optimal immunisation services. But before we delve into the world of immunisation, I want to provide you a little bit of an update, and I'll be very brief, about some of the other stuff we do in public health, so the work with infectious diseases and the work in environmental health. The pandemic is certainly, well, COVID-19 has certainly not gone away, so we're still incredibly busy in that space. But public health has also been working really hard in a lot of other areas. So infectious diseases obviously continue to pose a significant public health concern, and it's our responsibility in public health to monitor, prevent and control the spread within our district. Over the past year, we've seen fluctuations and some really interesting trends occurring with our notifiable diseases. So influenza has been a really interesting one. During the pandemic years, we had 2 notifications for 2021. I think I'm looking for my CNC down the back. And then obviously it just went through the roof again when the swabbing was introduced, where they swabbed for RSV, flu and COVID. And again this year we're going to be, please brace yourselves for another busy year. Arboviruses, so those pesky mosquitoes, they spread some really nasty diseases, and we've experienced that out in our district. And also sexually transmitted infections. We're seeing some interesting things happen in the STI space and with what's happening with our chlamydia, gono and syphilis. So influenza remains that seasonal threat to our community. We had that decrease in recent years, but obviously we need to remain vigilant. And influenza vaccination campaigns are incredibly successful in increasing vaccination rates. So please continue to promote and advocate for flu vaccination among our community members. By protecting individuals, as you all know, against the flu, we can reduce the burden of our healthcare system and save lives. So I mentioned the pesky mosquitoes. So we've been really busy with turning our attention to a virus called Japanese encephalitis. This is a virus that we didn't have to worry about in New South Wales up until early last year when it was detected in pigs. And it was then a little bit of work was done, a sero survey, and we identified that humans in New South Wales had been exposed to JE. Sorry. It's a mosquito-borne virus, has the potential to cause severe neurological complications and poses significant public health concern. Prevention and control strategies play a vital role in managing JE virus in New South Wales. Vaccination, thank you. Lovely. Oh, I zapped you, sorry. So vaccination is one of the primary prevention of JE. So also we do a lot of work in eliminating mosquito breeding sites using insect repellents. So we distributed, I don't know how many tens of thousands, tins of rid and mosquito repellent. We also encourage people to wear protective clothing and obviously reduce exposure to mosquito bites. The public health authorities in New South Wales closely monitor the mosquito population and conduct surveillance for the virus to detect any potential outbreaks. So you may have heard of the mosquito trapping that some of our local government partners do. It's a fascinating program, and I won't go into it here because we're going to talk about immunisation. But these are just one of the measures we put in place where we monitor mosquito numbers. And there's also sentinel chickens, and I know that sounds a little bit funny, but there are literally chicken flocks based around our LHD that are bled on a weekly basis and are used to identify if we have and detect Murray Valley encephalitis or Japanese encephalitis. It's all something that we get very excited about in public health. So if you ever need to or have a desire to find out more information, just give me a call. So additionally, the STIs continue to pose a significant public health challenge. We've seen an increase, as I said, in reported cases of gonorrhoea, chlamydia and syphilis. It's crucial that we focus on on comprehensive sexual health education, accessible testing and timely treatment to prevent the spread of these infections and promote sexual health and wellbeing within our community. Alongside all these infectious diseases, it does have the environmental health element, but there's also been some demands specifically in the environmental health space. Brad mentioned some of the challenges we've faced across the district in the past 12 months with fires and floods in particular. Those unique environmental challenges pose a risk to human health, of which we're involved with our environmental health team. So that includes water quality. So the flooding poses a significant issue to the drinking water supply in some of our communities, so we work closely with our local government. We work with the EPA, Environmental Protection Authority, looking at air pollution, so particularly in our locations across the district that have production in mines, etc., where that production of dust is quite significant, and other occupational hazards. So we work closely with various occupations, particularly in the mining sector, in Broken Hill with blood lead levels. So there's some of the key concerns that we've faced. It's our responsibility to ensure, as I said, safe drinking water and working with those industry partners to mitigate any potential health risks associated with exposures in the environment. By implementing effective environmental health programs, we can protect the wellbeing of our community members and promote a healthier living and working environment. Just to go through some of our immunisation, which others today will go through in more detail, we're doing incredibly well, as we have done for many, many years in our childhood vaccination space, with our rates continuing to be above the national and state average. Aboriginal children vaccination rates are also above the national and state average. There is a little bit of work to be done in the 1-year-old Aboriginal children, but I know we can do it. The school vaccination program, massive amount of work this year. Kendal will go into more detail, so a big thank you to everyone that's been involved in the school program. In review, our HPV Year 7 dose 1, 73% with the state average at 71. Females for Year 7, 77, above the state average of 75. DTPA in the boys and girls, 75, again above the state average of 71. And the men ACWY in Year 10 males and females is 63, just a smidge below the state average. We've talked about flu. Oopsies. Just to really emphasise the point. Flu, we're in the middle of the season. We are we had an early start to the season, and we're expecting it to be quite a significant season this year. We are seeing increased cases across our LHD, seeing a lot of RSV as well, but I'm probably not telling you something you haven't already witnessed in your own workplaces or community. The flu vaccination rates are doing okay. There's still a lot to be done. So a couple of towns to mention, Gill and Bree. In Gill with your young kids doing really well. Brewarrina in your 5 to less than 15 doing really well. Canamble's doing an amazing job with the GP there delivering over 80% of the vaccinations in the town. Orange AMS has provided almost 50% of the vaccinations in their practice for Indigenous people in that LGA. But we need to do more work in the 5 to 15, so it's that area that we struggle with year to year, but they're also that pocket of our community that do a really good job of spreading viruses, particularly flu. COVID vaccination, I think that's going to be one of our never-ending issues and concerns with access to vaccines. The COVID rates are consider them here to be moderate to high, and it's, as you would have seen in the media, that we're entering the 5th wave. COVID testing, there's been the changes that you'd be aware of with PCR testing going and needing a referral from your GP, but more information for that can be found on the website. This is our vaccination uptake. You can see the huge amount of work that was done, and then the continued efforts that have been made across our district. Again, more information about the vaccinations over time and the amount of work. It has entered that more complicated period now with the ATAGI advice being vaccinate 6 months after illness, so it's sort of added an additional challenge to the rollout and continued vaccination across the LHD. So in conclusion, we gather here today for the immunisation. I'm going to call it a professional development day, but call it what you'd like. Let us remember that our work in public health extends beyond immunisation. By staying informed, collaborating with your colleagues and addressing infectious diseases and environmental health issues, we can make a significant impact on the health and wellbeing of the people across our LHDs. So thank you for your attention, and I wish you a very productive and inspiring day of professional development.
Thank you, Priscilla. Kindly did remind me I need to get my flu vax. So Michelle, you can tap me on the shoulder yet again. So please welcome Kendal Ball, Nurse Unit Manager for the School Vaccination Program and Public Health Nurse with the Public Health Unit and Western New South Wales LHD to present a school vaccination program update. Thank you, Kendal.
Hello everybody. I know some of you, don't know all of you, so welcome. I'm going to talk about the school vaccination program. There's been a couple of things happening this year. It's little things. So I'm going to give you a yearly update. I'm going to keep it, I'm not going to give you a lot of stats. I think a lot of other people will sort of cover all that and coverage rates. I'm going to concentrate on two main things that have been going on this year. I'm Nurse Unit Manager of the Immunisation program, school vaccination program, / public health nurse. And this year there's been not much time for public health nursing. It's been mostly school vaccination stuff. So firstly, I'm going to talk about CAMI. So CAMI stands for Consent and Records Management for Immunisation. So over the past few years, we've had a transition from paper consents, which were packaged up at the end of the year, sent to Belinda, when she was the nurse unit manager of the school vaccination program, at the end of the year she would package them up, send them to Fuji in Sydney. They'd then get scanned, and then they would go onto the AIR eventually. So that then moved to a scanning system where we scanned on site. So all of the people who work in the outlying areas in the school vaccination program would know that they had to send me their cards. I scanned them. If they were Year 7 cards, I then sent them back to them. However, that improved the time onto the AIR for the vaccinations. And then this year we've moved on to an online program. So parents go online to consent for their children's vaccinations. We then take our iPads to the schools and we conduct the whole clinics on online. Okay, so it was an online solution. I've done a Priscilla and I've gone off the script. Online solution for the school vaccination consent. So the new consent program is based on, for any of you that worked in the COVID program after it left CHOC, it's based on the VAMS platform. So they've modified it. It's on service now, and it's we modified the VAMS program which they use for the COVID program. It replaces paper-based consents. However, there is still a need for paper-based consents. And the online consents are through the Service Now portal. Some parents are unable to use the online consents, so if you've got visa holders who don't have a Medicare number, they need paper consents. Part of the... Originally, when they were building it, there was no need for you to have a valid Medicare card to consent for your child, but then Optus happened, and they needed to verify and up their security and everything, so the Medicare number came into it as well. And the other people who might have to use a paper-based consent are some children in out-of-home care. So if they're in out-of-home care and they've gone to a carer and they're not yet on their Medicare card, they may need to use a paper consent as well. And also there's some tech illiteracy out there as well, and so there's a small amount of cards for those who can't really use the program. Oh, hello, there's another one. Details from paper consents. So the paper consents then get entered into the program by myself. They either get sent back to me or we pick them up on the day of the clinic, and we enter them onto the program, which has made a little bit more work, but works well. So that's just what it looks like. So that's the landing page where it says school vaccination program. So that's, for the people that have worked in the program, that's where you land when you log on as a staff member, but that's also where you land as a parent, and then you have to select staff or Service Now. So with the CARMI rollout, we delivered 93 iPads across Western New South Wales and Far Western LHD. IT hated us because they were all lumped on them and said, oh, about mid-January, and said they need to be done by the time school goes back. So they had to format and put everything on the iPad before that. And each staff member uses an iPad at a clinic before when we're vaccinating. We had online and in-person training provided for casual and community health staff participating in school vaccination. So the Ministry of Health created an online training program for the casuals that work in the program. And then we had a project officer who was helping out, sort of training outlying areas and community health staff. So we had a temporary project officer, the lovely Michelle Duffel. So for everybody who's worked in the VAMS, thank you. No, really, because she has been awesome. She has made my life so much easier. So she's travelled around the district. She's attended most of the first clinics in every single, for here and northern sector, so all the way out to sort of Galagambo and places like that, helping out with the first clinics, making sure the iPads are working, making sure that there's IT service, you know. So that has been amazing. So there's an online solution coming for remote locations with no internet service. So we thought we might have 1 or 2 locations that didn't have internet service, so the iPads wouldn't work. But it turns out we don't have any. So it's going to be more of an issue in the northern sector and in Far West. But that solution's not coming till June sometime. Okay, what's next? So The online consent program was released on about the 4th of February, and on about 2 days before that, it was within a week, the ATAGI and the TGA and all the important people said, oh no, we're going to reduce HPV to 1 dose. So everything on the online platform was based on a 2-dose schedule. All of the paper consents which were delivered in about November were based on a 2-dose schedule. So it created a few little problems. So everything had to change. The online program had to change, which it didn't immediately. It had, little prompts for people to say you're only consenting for 1. But we couldn't make any changes. So we knew this change might be coming in December, but we couldn't make any changes until the Chief Medical Officer and the Chief Health Officer signed off on it. So everything was amended, and extra information about the changes was attached to the paper consents and the online consents. And online comms for schools were sent out, and there were, like I said, there were stickers on, and so we had to stick every sticker on every paper consent before we were allowed to send it out. So that's what we did. We took it home for the children to stick them on. The admin ladies, every single time they were quiet, they just grabbed out some consent forms and started sticking stickers on. So it was a pretty mammoth effort. What page am I up to? Okay. So what are the benefits to the online school vaccination program? So there's no more cards lost in school bags, or just not given to parents, or accidentally chucked in the bin on the way home from school. The AIR history is visible in the clinician portal. So when we're vaccinating, previously we would not be able to see the immunisation history, and a lot of the time it probably wasn't up to date anyway. For the school program at least, but now we actually have a button in the program before we vaccinate, we can check their vaccination history. Vaccinations after we give them are visible on the AIR pretty much immediately. Now with all that scanning and had to be sent to Sydney to be scanned and all that in the old system, it was up to 22 months before it was actually on the AIR. No more posting cards around New South Wales, so no more losing cards or any of that. Parents receive a notification immediately after the child's been vaccinated by text or email, however they've chosen. It's pretty easy for parents and carers to use if they're tech savvy and if they're familiar with the ServiceNow app. And once they've consented 2 days before the clinic, they'll get a reminder that the clinic's coming. And there's also a function to notify the parents after a clinic if the child didn't show up or they're absent, just to prompt them. Less burden. Well, I don't know whether school teachers would actually agree with this, whether there's less burden. I think the admin staff at schools would go, oh my God, I've done so much running around for you just lately. But I think eventually there will be less admin work to do. And there is talk of sort of bringing out a pamphlet for the parents to send home because teachers like to hand out stuff. And verbal consent's still possible. So at clinics, what we've been doing is getting children who aren't consented online, and we've been getting them to, unless their parents have specifically requested that they not be vaccinated, we've been getting them to come to the clinic, and we can ring the parents, get consent over the phone, enter their details online. Yeah, and probably another benefit is that it's allowed better engagement with our outlying areas. So previously it's just they chugged along, doing it their own little way, but this has brought up a few issues that maybe we could, get a bit better uniformity in the system. Barriers to the program: parent-carer technological capability, data, smartphone access and IT literacy, parent-carer engagement in child's health outcomes. So in lower socioeconomic areas where there might be a few family issues and a bit of poverty, there tends not to be as high consent rates. Some schools I've discovered don't use online platforms like Compass and Central, so that's been a little bit of a challenge. There's been a couple of schools that we've had to base it entirely on paper consents, which is not ideal, but it's got the kids vaccinated. And it is a bit labour intensive at times. We've had to roster extra staff on for clinics. The clinics where I've ended up with not extra staff have been interesting. Okay, so here's just a few little preliminary stats that I put together myself. so what I compared was 2022 dose 1 HPV when we showed up to the schools to give dose 1, and so I didn't do the whole year because I didn't think it was an accurate comparison. So most of the schools we've done better, equal if not better, than what we did for dose 1 HPV last year. And as you can see, Condo High is like the star of the show. They went from 20.5% last year for dose 1 HPV to 83.3%. And at the end of last year, when they'd done all their catch-ups, I think Condo was still only sitting at about 45%. So a lot of that was down to the admin staff at the school ringing parents and putting in a lot of effort. There is a couple of schools who are below what they were for dose 1 last year, so that needs a little bit more reviewing to see why that's happened. But overall, it's very positive so far. Okay, HPV dose changes. I'll do this really quickly. So I've taken all this information from an NCS webinar that was on the 5th of May. So if you haven't watched it, go and watch it. If you haven't subscribed to NCS, subscribe because they've got so much interesting information. You'll get a little newsletter once a week, and they'll also invite you to webinars on things like HPV, Mpox, all that sort of stuff. So it changed at the same time as the CARMI program, changed from a 2-dose to 1-dose schedule, and that became official in January. All children who have had 1 dose of HPV vaccine are considered up to date, so even if they were catch-ups. The whole town of Forbes was happy about that because we couldn't go and give dose 2 HPV because of flooding to them last year, and then they cut it down to 1 dose, so they were cheering. In 2022, the WHO recommended that 9 to 20-year-olds get 1 or 2 doses of HPV vaccine, and above 21 years, 2 doses, and immunocompromised 2 to 3 doses, preferably 3. So Australian recommendations are 1 dose of HPV vaccination up to the day they turn 25, and that's from 9 to 24 years. But immunocompromised still get 3 doses. So the New South Wales School Vaccination Program, sorry, I'm reading the wrong page, has 1 dose in Year 7. So this is just a bit of why. So the WHO carried out a systemic review of 55 studies on HPV vaccine, both 9-valent, 2-valent and 4-valent. 1 dose is effective in a 9-valent study. 1 dose is equivalent to 2 or 3 doses in multiple 2- and 4-valent studies. And in the long-term, seropositivity of 1 dose is similar to that of 2 to 3 doses. And so the plan is if protection wanes in the future, longer-term evidence will be available. So they'll continue to monitor the seropositivity in the long term. And it'll be relatively easy to switch back to a 2-dose schedule if they need to with a catch-up. It won't, if 1 dose doesn't turn out to be right, it won't necessarily mean an increase in cervical cancer will be what prompts them to go back to a 2 or 3 dose schedule. It's more about the seropositivity and the monitoring. So I've already said that. Another thing I wanted to mention is I've had a lot of questions from parents about the HPV vaccine. I think they're all a little bit, just a bit on edge after all the COVID stuff. So just wanted to direct you to the NCS website and the Sky website. And you can give them those and tell them to go on, because there's a lot of good research on there for parents. So the school vaccination program, where to next? We're doing better spacing of clinics because there's no rush to get a 6-month gap between vaccines. And there's more opportunities for us to give catch-up vaccines at the end of the year. There's a little bit of less vaccine hesitancy, I think, due to there not being multiple doses. And just, one thing I wanted to mention, in smaller schools, if any of you help out in the school program or if any of you run clinics out sort of in outlying areas, make sure you're offering all the vaccines at all the clinics at smaller schools, because opportunistic vaccination makes a huge difference in rural communities. And that's it. Thank you.
Thank you, Kendal. Very excited to see the online learnings. To be honest, every time I see the word paper, I do twitch. So it's very good to see. Please welcome now Belinda Tracy, Acting Manager, Immunisation and Communicable Disease, Public Health Unit, Western New South Wales, LHD, to present vaccine management and audit feedback.
Thank you very much. Hello and welcome. Thank you for the kind invitation to present today. I'm actually presenting vaccine management and fridge audit feedback, but all of this work was a body of intense attention by Rachel Fay, but unfortunately Rachel couldn't be here with us today. So I'm filling in for her, so bear with me because this is her presentation and I'm going to fudge it. So random vaccine audits, they are in the GP setting predominantly. They've been interrupted over the COVID process, so they've been recommenced this year. So this presentation will reflect the information gathered from those audits thus far. All right, so we've got the principles, the basic principles that all facilities need to embrace when we're looking after vaccine storage. So we need a purpose-built fridge, and everybody responsible for handling vaccines needs to be educated on that. We need to nominate staff member responsible for vaccine management and backup person, and that might be the nurse, the doctor, the admin, it can be anyone. So embrace your team, get them in. Policy, procedures and protocols need to be in place and reviewed annually. Everyone who's involved in vaccine transport, storage and administration need to be trained in vaccine management. So don't forget you've got your heady training that can be done by everybody, and we recommend that actually annually now with your CPR training, because there's lots of updates that go into that heady training and that can certainly just debunk a lot of myths. So by sharing that responsibility, it allows lots of staff to play a role in keeping your vaccines safe. So in the event of illness, going on vacation, so others know what to do in the event of a cold chain breach. So we need to be monitoring our temperatures twice daily, or more if required. So if you're stocking your fridge, check those temperatures and make sure your fridge is happy. Ensure plans are in place for response to cold chain breach and all staff are aware. Report temps to the public health unit that are outside 2 and 8 degrees, and follow the guidelines using ice and gel packs and monitoring vaccines in coolers. Don't reinvent the wheel. If when you're looking at your policy and procedure manual, the Strive for 5 guidelines are there. They're there to help you, so use them when you're developing your policy, procedure and protocols. And that helps you include your information to make it site-specific. So every site's going to be different. Who's there to help, who's going to have what role, but use your entire team. And don't forget, if you do have a cold chain breach and you're on the edge and you're not sure, please just give us a buzz and have a chat. It's better to be transparent than risk immunising patients or clients with ineffective vaccine. So Rachel's just popped a few pictures up here of some of the vaccine fridges that have come back. Some are good, some are great, some are a little shocking, a little overstocked, sharing the fridge with a few extra bits and pieces. So as you can see, it's a busy space. All right, so the vaccine fridge audits, they're random and you get a little bit of guidance when we send out the audit on what to do, what to send back. So basically, overstocking, let's have a look at the points here. Mandatory to be completed and a stop will be placed on your vaccine if not submitted. We've all got to be doing an audit on our fridges every single year. Complete the New South Wales Health General Practice form sent in the email. Heady vaccine cold chain management certificates are required so we can see evidence that at least 2 people have completed that training in each facility. We ask you to complete the Strive for 5 annual audit and on top of this one. So just that small audit that's in the Strive for 5, that's pretty simple to just tick through. We ask for a copy of your policy and procedure for cold chain management. So just making sure that there is a policy. You need that for accreditation anyway, so we just, we can take a look at that and help you update that if you need. We require 72 hours of data logging, 3 days prior to receiving the audit, and a copy of the current twice daily temperature chart and the photo of your fridge. So that's what helps us sit there and see what's going on with the fridge audit. And the photo just helps identify what's actually going on, as you saw in that previous slide. What we have found from the audits is that the self-audits are not being done annually. Some fridges have not been serviced annually. Urine specimens have been stored in the vaccine fridge. Temperatures have been set in Fahrenheit instead of Celsius. The data logger monitoring has been every minute or every 30 minutes. The calibration of the data logger was set outside 2 to 8. Some cold chain breaches were not reported. Data logger not consistent with the min-max temperatures. So, you know, the min-max chart's looking fabulous, but the data logger is telling a completely different story. A lot of out-date policy and procedure manuals, just not keeping up with the changes. So on your min-max temperature chart, there's no notes written explaining why temperatures may be outside of range, so it might be just stocking a fridge. So that little comment section, just make sure you put a little dot there to, you know, to be able to explain your temperature fluctuations. Temperature's been rounded up or down. I know it might be only 0.1, but it's a very important 0.1, so keep adding it. Open vaccine boxes, we all know that, our vaccines don't like light, so keep them in their boxes, pretty please. Vaccines or other things placed on the bottom of the fridge, so that bottom shelf of the fridge where there's no wire rack, things have been stored quite heavily down there, so we do ask to promote that air circulation, that we're mindful of not packing and stacking that bottom area of the fridge. Battery changes are missing from some of your portable devices for temperature monitoring, and slush tests are not being completed. Some people haven't really known what a slush test is. So again, we just encourage you to use your Strive for 5. These audits, for those in the room that work for the district, we complete our audits on a system now called QIs. So it's the same but different. So I know this is driving home the message in the GP setting, but that QIs system is also trying to achieve the same outcome. So that's important. So we just got to really push in the whole fact that, we don't need a minimum amount of people from each practice being champions for cold chain management. Everyone in that practice can be involved in that, or community health centre, or department in a hospital. The more people that know about cold chain management, the least amount of wastage we might encounter. So just ensure that your min-max temperature is definitely checked twice a day, and ask a friend in that unit to help you with that. And name your data logger. Give it a name so everybody can identify which one you're using. Some places have more than one. And if you've got multiple fridges, give them a name too, so it can all be linked quite easily, and it's whether it's numbering or nicknames, it doesn't matter. So looking at the big picture, costs associated with loss of publicly funded vaccine. I'm just looking for her notes on that one there. So for 2022-23, in the last 3 quarters, we had a total of $40,739 worth of vaccine go down the drain. So that's a lot of money that we've wasted. I know sometimes wastage is just part of the course, but predominantly this money was through poor cold chain and fridge management. Practice and patient costs related to missed vaccination clinics and inconvenience for patients and clinics rescheduling. So time to reschedule, patients need to rearrange times and dates after already possibly taking time off. You know, it all compounds. So if we're looking after our vaccines and we're on top of that before a clinic starts, you know, you're definitely going to have clients that are going to like you a lot more. Medication safety. So wanting to avoid immunising patients with ineffective vaccine and increase risk of outbreaks to vaccine-preventable diseases. So keep patient confidence in vaccines and immunisation providers. So yeah, so I think we all know what to do, but just reminding yourself that, yeah, ineffective vaccines are a waste of everybody's time. So what can you control? Well, you cannot control cold chain breaches related to things like power outages. There are variables within your control, such as fridge maintenance, having knowledgeable staff who can monitor temperatures, recognise when to call the public health unit, and move vaccines if required to decrease exposure outside cold chain temperatures. So having that plan B or plan C, whatever it might be. It might be another practice that doesn't have the power outage. Have a relationship with other people in your town. If you need to move vaccines, you can ring them up and share a fridge space, hopefully. Don't forget, you can always contact your hospital to see if the pharmacy, and some hospitals even have vaccine monitoring on pathology fridges. So there's options. So staff turnover has also been a big problem. How can you assist in the forwarding of information? So when you leave a premises, a lot of people are just leaving and walking out with all that knowledge. So we encourage you to keep a book, a folder, anything, just to keep everything organised, but so others can have access to information which assists in the practice running long term. Plus, it's just a nice thing to do. If you're a new person in a new practice, you know, if you've got that book of knowledge that you can go to ensure that you know what's going on with the vaccine ordering, the vaccine management, training, and etc. You know, having that little Bible really does help. And nonetheless, you know, having all these procedures in place, it contributes to your practice accreditation. It's a laborious process, practice accreditation, and if you can be performing these activities every single day, you know, it's not going to be a new thing that you have to add to your practice accreditation process because it's already in place. You're using it every single day. And that's about it. So Rachel does thank every single person out here that has contributed in a vaccine audit thus far. They've been really great. It's really great to talk with each and every one of you with any breaches in cold chain management. If you're new to practice work, please reach out to the Public Health Unit if you need any advice, but don't forget you've got a whole room full of people around you and your local area to help. So if you need any more information about the audits, just come and ask me. And just for your information today, the audits will start to be rolled out into the pharmacy sector as well. So as they are now holding the NIP vaccines. So that's a body of work that we're about to commence. So that's it. So thank you for listening to Rachel's presentation. It was a great body of work, but overall everybody has done a really great job. And we'll see if we can cut down our financial losses from vaccine wastage in the next financial year. Thank you.
Thank you, Belinda. Okay, so now it's time for our Q&A session, and it's going to be facilitated by Priscilla. So Priscilla, if I could ask you to come forward, please. And also welcome back, so don't go too far, Belinda, and Kendal to join the panel, and Katie Pryor, Manager Education Programs with the Western New South Wales Primary Health Network, to share the Slido questions, which you can submit now if you haven't, or please raise your hand and wait for a roving microphone to ask a question. In fact, do you mind, Libby, if I can ask you to help with one of those roving microphones and I'll take the other? Ladies, if I can just get you to come to my left here in the front. You're the heroes. Yep, centre stage. Yep. Okay, you can take... So you're facilitating for the guest panel members. And Katie's just going to read some of the Slido questions to begin with.
Do we have a...
First question?
There we go. Yep.
Oh, there we go,
Okay.
we're on.
Have we got one in the audience? Our first question is, can a teenager give consent if their parents decline?
No. Why is the first question for me? No, they can't. So in the community they can. So if they were to present to a GP surgery and say, over the age of 16 and say, I need to have a vaccination and my parents won't consent, they're allowed to have it. In the school program, we won't do it without parental consent. It's just a bit too much of a political minefield. So, yeah, but they can have it at other places, but not in the school program.
Okay. While you're there, Kendal, oh, you're going to answer some more, Priscilla?
What?
We've just got another question here. Given the impact of flu this year and low vaccination rates in 5 to 15-year-olds, would you consider offering clinics in schools using CARMI?
As in a primary school? Or high schools for influenza?
5 to 15-year-old range, so...
Not for flu. No.
Okay.
It's just not the resources to do it. Yeah.
Absolutely. Here's another question. How often should the data logger be downloaded on the vaccine fridge?
You could have answered that. Weekly would be the best time to do that. But of course, if you experience a breach or things just aren't adding up, do it more frequently. Check your parameters every time you do a download, and don't forget to restart it. But yeah, weekly.
Yeah, okay, perfect. Another one here regarding vaccine fridges. Can the public health unit come on site visit to help get immunisation fridges up and running?
We certainly can, but be mindful, you're looking at 50% of the team here. We are a small team and we have a very large geographic area to look after. But yes, especially with a new setup, we really do push for that local visit, the site visit, to help people set up and make sure that they've got all the equipment they need for vaccine management. But yes, if you'd like a site visit, please send us a message and we can certainly visit and help.
Perfect. Any from the room that we want to ask?
Come on. What about our new person? Nothing?
No.
Okay, no questions.
So there's another one here about how long do you have to keep paper fridge temp charts and data logger printouts for?
Oh, that's a good question. That's it. I think. What do you know the answer? 25 years.
What?
Oh. Turn on your microphone. Because I would have done 7 years, keeping it the same as medical records. Michelle, wonderful. So yes, it's mainly for the children's ages. So keeping a child's record for 25 years is the same for all your data records for cold chain. Turn on your microphone, Michelle.
Yes, yeah.
Would you like to come to centre stage, Michelle? No, you're right. Don't be shy. It's okay.
I'll turn around.
Are there any more questions? Any hands? I did say that lady's hand up here earlier. No? Okay.
There are some questions here around varicella and pneumovax. Will they be covered later in the presentation or...?
Yep, Nick's covering that.
Yeah,
so let's
yeah.
let the pro
So we might
do his thing and we'll go from there.
Carry those questions over to the next session if that's okay.
Here's one. Sandra.
Oh, what is the slushy test?
Oh, do you want that back?
See, there you go. Not many people know about the slush test, but basically that is just testing your mobile, your transportable digital thermometers and bits and pieces. So literally putting your temperature probe into a cup of ice and making sure that the temperatures plummet, and then into a glass of water. So just making sure that, you've got a thermometer that's actually reacting to temperature change. So it's a very simple process. It's not a complicated thing, but it's just to make sure that you've got a probe that's actually showing a digital change on your device. So, it's a very simple thing, but important nevertheless.
With the vaccine fridges, I spoke to the fellow that services them, and he said he does it through service, because to pull the probes out of the actual vaccine dedicated fridges, it's quite difficult. So
no, it's just the mobile. You know, if you've got to put vaccines in a fridge for transportation, it's those little digital thermometers.
Not for your purpose-built fridges.
No, you leave your fridge servicing to the fridge servicing technicians.
Thank you.
Yeah.
Any more? More? Going once, going twice. All good? I think everyone's keen to get their sugar levels up, perhaps. Yeah.
I'm with you.
I second that. Thank you, ladies, for that. I appreciate it. Okay, so we're going to have our first word cloud for the day. So again, using Slido. Thank you so much. Please enter a couple of words about what is the best thing about being a nurse immuniser. Don't be shy. Now, it is time for morning tea break. This will be served in the green room, so off to my left, up through those doors there. And don't forget to visit the resource and sponsor displays during the break. We will reconvene at 10:55. We'll see you soon. All right, so I'd like to, can you please welcome Wendy Holmes and Alice Gordon, Aboriginal Immunisation with the Public Health Unit, Western New South Wales, LHD, to present an Aboriginal and Torres Strait Islander childhood immunisation update. Thank you, ladies.
Hi, I'm Wendy.
And I'm Alice.
We just want to, first off, we'd like to acknowledge the traditional custodians of the land we are meeting on and remind people that we live and work on Aboriginal land.
We would also like to acknowledge the Aboriginal elders of this community and those who have passed, all Aboriginal people attending this meeting today.
Okay, so I'm a proud Wiradjuri girl from Forbes, moved to Orange in 2007 to start a traineeship, then completed a Certificate 4 in Aboriginal and Torres Strait Islander Health, and then in 2013 I joined the Public Health Unit as the Aboriginal Immunisation Project Officer, covering both Western and Far Western LHD.
So I'm Alice. I am a proud Nambar woman from Brewarrina, which is where I'm currently based. Like Wendy, I've done my Cert 4 in Aboriginal and Torres Strait Islander primary health care and done my immunisation certificate. I've been in the child and family and antenatal role for quite a while, and I've just recently moved over into the public health unit in this role. Okay. So what we do, Wendy and I cover quite a lot of ground between us. Like I said, I'm based in Brewarrina, and Wendy is over here in Orange. Together we promote vaccinations as per the NIP for all, but focus on Indigenous children. We continue to review air data across every community in the areas that we cover. We kind of cross-reference that with some of the files we have access to ensure it's all up to date and happening nicely. So we support the school vaccination program wherever we can, travel to whatever community needs us, helping out with the new online portal for the vaccination program, which is great. We consult with communities wherever possible, promote the vaccination program anywhere that we can. If there's anything coming up, little invite and we'll show up and promote whatever we can. And we assist any other agencies. So if there's anyone with just questions in regards to whether it's individual children or, you know, anything at all, we get calls from Justice Health, DCJ, everyone. Just, they don't know who else to call, so they call us and we can just put them in the right direction or give them any information that they require.
Okay, so challenges that we've faced over the time, and this is something that's been ongoing. The Aboriginality is left blank, so it's not being asked. Medicare details, now, you know, duplicate Medicare details, not being up to date, you know, just with incorrect spelling of surnames, middle initials, etc. So just ensure that you check your Medicare details each time that they come in, just to make sure everything's up to date. Because as you know, like after a certain time, they get updated, so there's a new number goes on the end. Yeah, and then centres not having access to Prota and Air. If you come across that, you've usually got Michelle, you know, in medical practices and that. But you know, anything that we can help out with, you know, we can certainly. If we can't help, we can put you in the right direction. We also have a lot of transient families, so it's really hard to track down families that are moving, going across borders, because as you know, we cover. You know, as far down as Oberon, all the way up to the Queensland border, across the South Australian border, down to the Victoria border. So we have a lot of transient families that go across the state to different states. And then air, as we know, there's usually time lapses between the immunisations, you know, when they've been put on or when, you know, they've been ordered. Yeah, and so just check and make sure that you've got the correct dose numbers and things like that when you're putting onto air, because we're finding that that's coming through quite a lot. We have a lot of issues, you know, if the system's down, if air's down, you know, the vaccinations don't go across. If you get a child who doesn't have a Medicare number and you're trying to send it through on your medical director or whichever other practices that you have, it may put a hold on and stop all other vaccines from going across. Now, you guys usually aren't aware of that. You just think it's gone through unless either I contact you or maybe a parent. Yeah, and then we've also got, if you're privy to a child that may be deceased in your area, if you see them come up on anything, just, you know, like try and let Air know, because there'd be nothing worse than parents getting letters saying that their child's deceased. You know, like the child is deceased and they get letters to say their child's overdue, which, you know, on our hospital database, if they've passed away within our area, we can go on there and it usually will give us a prompt to say, be careful, this child is deceased. So, yeah, we do get quite a them that we have to ring Air to get them taken off the system. Yeah. Okay, now with our immunisation rates for children, so if you have a look, if you can see that, we're doing pretty good. I mean, there's a lot of work that does need doing on the 1-year-old levels, but we're 93.1% within New South Wales. Western Local is actually 92.7%, and then in Far West we're 94.4%. So we're actually above the Australian average, which is 90.7%. So on the 2-year-olds, we're 93.7% for Western, and Far West we're 100%. Which the Australian level is 88.5%, so we're above them. In our 5-year-old, within the Western, we're 98.6% for the Aboriginal kiddies and 100% in the Far West, so which means we've overtaken the full Australian percentage of 95.4%, and then yeah, it goes on with the 1-year-old in all age groups from 95%, and then the Far West 97%. 2-year, 94.4%, and then Far West is 100% in all children, and then 5 years, we're 95.9%, and Far West is 97.7%. So, yeah, we're beating the Australian level, which is 94%.
Okay, so results and future direction. So from here, we want to focus on, you know, our rates are looking pretty good, but we will still try and improve them as much as we can. You know, in the improved vaccination rates in the SVP and Aboriginal communities, We really want to focus on improving the influenza vaccination rates, especially in those high Aboriginal communities, and promote maternal pertussis and influenza vaccination rates.
Thank you.
Thank you, Wendy and Alice. Okay, so please welcome Professor Nick Wood, Staff Specialist General Paediatrician, Professor and Subdean Postgraduate of Research in the discipline of Child and Adolescent Health, University of Sydney, and Associate Director at National Centre for Immunisation Research and Surveillance. So for the next hour, Nick's going to give us an update across COVID, seasonal influenza and Japanese encephalitis and Murray Valley encephalitis update. Thank you, Nick.
Thanks very much. It's lovely to be back in the country again and out of the city. I always like coming up to Orange and Dubbo over these 2 days. Next year I promise to bring some friends from Sydney, some very bright young women staff specialists that we have working with us, so we'll get them to present to you as well. So in the next little while before lunch, I'll talk about COVID, flu, and then Japanese encephalitis. I'll probably stop after COVID to see if there are any questions, and then again after flu. It's really important for us coming out of the city and the National Centre to actually hear from you guys at the coalface issues that you're seeing and for which we can try and help potentially get some answers. So very keen to hear from you, so wanted to make it as interactive as possible rather than me just standing and talking. Also to acknowledge country, pay respect to elders past, present and emerging leaders. Okay, so COVID, what the last few years we've had. You can see sort of where we've come from. This goes back to 2022. This is hospitalisations. In the yellow, you can see the peaks there. And more recently, obviously the peaks are lower, but still around. And one of the things that we're trying to understand now is because pretty much all of us have had vaccines and natural disease, when we go into hospital and you're sick, you might go in for, diabetes exacerbation or something, but you actually get tested for COVID. Are you there because of the COVID or because of something else? So it's every person that gets hospitalised, we have to make a decision, is it because of COVID or just they happen to have COVID at the same time? This is New South Wales, up to most recently. You can see the little pink line there, which may be hard to read from the back there, but that's the over 90s. And this is notification. So it's still up above in the over 90s, and that might be because of testing in either aged care homes or in the community or other. You've probably heard a lot about the variants. So we've moved from the original strain to the beta strain to the delta strain to the Omicron strain, and within Omicron there's BA1, BA45. When the BA45 and the BA1 combine together, they produce the next variant, which is the one that's pretty much dominant now, which is XBB, and I think that's the one that they're calling Arcturus. So it's the one that's circulating the most. We don't think that it's any more significantly worse disease than, say, Omicron, BA1 or BA45, okay? And it probably is likely that the vaccine does give you protection. But what's been happening, as you know, is the vaccine companies are chasing our tail. So when the virus changes, they have to update the genetic code in the mRNA vaccines like Pfizer and Moderna to try and cover the new variants. So I think WHO is encouraging them to think about an XBB genetic code as well. But that's the dominant variant. Age, as I mentioned, is a big risk factor, and this graph at the bottom shows you what's known as a hazard ratio, which is the chances of dying
from COVID disease, and you can see that the numbers not too bad for the sort of mid up to the low 60s, but then beyond that, this curve goes up very, very steeply, and that just basically means that people who are over 80 are much more likely to die from COVID than the younger group, and I'll show you in data in a minute to support that. The other thing we know is that people with risk factors, and again a bit hard to read from the back there, but we can make all these slides available. Those group of people that have underlying medical risk conditions, immune deficiencies, lung problems, chronic neurological problems are also much more likely to die. So this is deaths from COVID. The NNDSS is the National Notifications Disease Surveillance System. So every time a case is notified, this gets reported at the state level, but then also nationally. And what you can see, which is highlighted in the sort of red pink bars there, is the deaths by age in the over 70s. And it's again, the highest group is in the over 80s. And the other thing to note, probably hard to read, I should look at the slides from the back myself, but in the younger kids, the under 17-year-olds, by wave, there's very few deaths. So the younger kids just really, fortunately, don't get too sick and die from Omicron. So I won't get everyone to put their hands up, but I think if everyone was sort of raised their hands below the table, if you've had COVID, I reckon about 80% of us have had it. And we know this from serological data. So what we've done is, in this particular study, is when people go to the Red Cross blood donation places to give their donation for blood, we take a little ampule as well, and we send that off to look for COVID serology. And we ask the people, did they have COVID or known to have had COVID as well. And you can see we've done that on 3 separate occasions. The beginning of 2022, the middle of 2022, and then towards the August, September. There is another one which we've done as well. And I think the take-home message is that down the bottom you can see the little grey bars. They're the first survey. The red is the second survey, and then the black is the last survey. Okay. And you can see pretty much in that sort of 30 to 50-year-old age group, when we look in the blood samples of people, around 60 to 80% have had COVID by testing for what's known as the nuclear capsid antibody. Okay, so that's important because most people then have either had 2 doses, primary course of 2 doses, plus natural infection, and together we call that hybrid immunity. Okay. And that's important because it then determines how we decide what booster dose schedule should be. So we'll be able to tell you the latest survey, which will be probably out very soon. It's probably likely to be higher again. Okay. So that's the over 18s. If we look at the children, similar sort of story. So it's a little bit more complicated because what we're showing you here is nuclear capsid antibody, which you only really have if you've had natural infection, okay, or spike antibody, and that's what you get from having had the vaccine. Okay. So you can see that in the sort of 12 and above, close to 100% have had, spike antibody, which means they've had vaccine, okay, which fits with the coverage that we know, about 80% or so have had 2 doses. Nuclear capsid in those over 12s is around about 70%. So around about 70% of over 12-year-olds have also had natural infection. What's interesting is the 0 to 6 months, and you can see that it's about 30% of those little young infants have also had COVID antibody. That's probably either from natural infection or given to them by their mother, who may have had natural infection, if that makes sense, because the antibody that mum has passes to the baby. So the antibody does provide them some protection. And then in the 6 months to the 4-year-old age groups, you can see around about 50 to 60% have also had natural infection. So that's what we know from community surveys. Okay, so hopefully you've seen these particular new flow charts. This is the booster dose advice. I think, did I show the... No, I'll go back. This is the booster dose recommendations, which I'll come back to towards the end as well. But just to go through it, under fives, the primary course for the under fives is really the two or three doses, depending on which vaccine you use, and it's mainly the at-risk kids. But the under fives, no booster dose at this time. The easier group, the over 65s, yes, you should get a booster dose if it's been more than 6 months since your last vaccine or last infection, okay? And then between those sort of 5 to 65, it's a little bit more complicated. From 5 to 17-year-olds, you sort of have to think, do these people have underlying risk conditions? Okay. If it's a yes, then ATAGI's use this word consider. And that may not be much of help at the front line. So I'll show you a little bit about what we mean by consider. So then you guys can consider it and talk to your patients. But if you don't have any risk factors and you're 5 to 17, then really no rush to get a booster dose, okay? If, however, you're 18 to 64 and you don't have any risk factors, you can consider, but if you do have risk factors, then you probably should get it, okay? But I'll say some more about what this magic word consider means, and then perhaps you guys can tell me what you're seeing at the front line. Okay, so this is an attempt to try and summarise the vaccine effectiveness. So when we look at how effective a vaccine is, one way to think about it is, does it stop me from dying? Does it stop me from being hospitalised? Or does it stop me from getting infected? Okay. The vaccine is pretty good at stopping me from dying or getting hospitalised. Okay. You can see that's the top dark blue line. The primary series, you get good protection after the first couple of doses. It sort of falls away a bit to 6 months, but then a booster dose bumps it up so that you actually get some good protection from the booster dose against severe disease. However, the vaccine, which is the light blue line, you can see that the protection doesn't really stop you getting symptomatic disease. So there are many people out there who said, I had my 2 doses, I had my booster dose, yeah, I still got a bit of COVID, but I wasn't too bad, I didn't end up in hospital. So it doesn't actually stop you getting symptomatic disease too well. But a booster dose will, as you can see on the bottom line, it does bump up a bit, but it falls away fairly quickly. Okay. So that's what we know. And in terms of putting some numbers to that, the bottom is the COVID vaccine, and this is against Omicron. You can see that, as I was talking about before, the severe disease, it's effective up to about 6 months after the first bit, and then the booster gives you sort of that 80% mark, okay? And that's for severe disease. Against symptomatic disease, not so good, and the effect wanes. Just the top two really show you the comparisons with the measles and the pertussis vaccine, which is why we don't have to keep giving a measles booster every few years like we are doing with COVID, because the measles vaccine is a good vaccine to provoke a really good, robust immune response. It's a live vaccine, okay? And the pertussis vaccine, as you know, we give booster doses as well, and we get pretty good protection, but not as good as the measles vaccine, but better than the COVID vaccine. Okay, so that consider statement, what does it mean by consider? So the questions that people might think about is, I want to reduce my chances of dying or going to hospital. And like I said before, we've all had a couple of doses, maybe 1 booster, maybe 2 boosters, and hybrid immunity because we've had natural infection. So the booster dose will probably give you, if you're over 65, a good protection against ending up in hospital, okay? I don't want to get sick because I wanted to travel. Well, in terms of preventing infection, like I showed you before, well, it's not, a booster dose may not really give you huge protection, okay? I don't want to pass it on to my grandkids or other people. Vaccine is not very good at stopping infections, okay? So if that's the reason they want to get vaccinated, well, you can say, well, it won't stop you getting infected, Might stop you end up in hospital, but it won't stop you passing on the infection to others. Okay. So that sort of 65 cutoff is a little bit arbitrary. If you've got someone who's 64 and there's been 6 months since their last dose and they're travelling to the Northern Hemisphere and they're about to get on 4 or 5 different planes and they're otherwise okay, a booster might well be good for them. Okay. But if they're 18 and they've had their 2 doses and 1 booster and they're not going anywhere, the boosters may not be that relevant for them. That's the problem with the consider statement, and we're interested to hear what you guys think about what you're seeing at the front line. I won't go through this in detail. I'll leave that one with you talk about. Now, it is confusing. These are the original formulations, okay? To be honest, they're old school, and the company is probably not even going to make them anymore, okay? So the Pfizer original strains probably won't be, the company's shutting down the manufacturing of them. So we're now in the bivalent era, okay? Bivalent means that they have the original strain mixed in with the Omicron strain, okay? That's how they basically cut the vaccine. You can see that there's BA.4/5 ones and BA.1, okay? Both Pfizer and Moderna have that. One of the thing to note, which you probably again can't quite see from the back, is that the approved age for the Moderna and Pfizer BA.4/5 is 12 years and older. Okay, so that's important to remember, because if you can't give the 4/5 booster to a 10-year-old, okay, 12 and older. If I had to choose between BA.1 or BA.4/5, I'd be going with the BA.4/5, to be honest, if it was in my fridge. But if I didn't have it in the fridge and that was the only opportunity I was going to see that person, I'd give them the BA.1. Yep. The other thing that's quite neat about the Moderna one is, I'm pretty sure, is it there? It's got you can see the picture actually. It's got the needle and syringe already made up, okay? So that's an advantage. All right, so what about you guys as healthcare workers? Should you get a booster dose? The sort of party line, if you like, is that if you're 18 to 64 and you have an underlying medical condition, then you're the same as any other member of the community, and it probably is worth getting a booster dose if it's been 6 months or more since your last dose, okay? But other than that, if you're, like me, I've had my 4 doses, I've had natural infection, am I rushing out to get a booster dose? Not just yet, but I'm just watching and waiting. But if I was worried about getting the COVID, if I had other members of the family that were, say, immune suppressed or something I was living with, then I might think about it as well. Pregnancy. So the guidance also says that consider them like another non-pregnant person who's 18 to 64. Again, if they have medical risk factors, they should get a booster dose during pregnancy. This is the current recommendation. This is slightly different to what WHO's SAGE, the SAGE is the Strategic Advisory Group of Experts. They're actually recommending that women do get a booster every pregnancy. So time will tell whether we follow that, but at the moment it's consider it as you might any other 18 to 64-year-old person. Can you have it at the same time as other vaccines? Yes, you can. So if a 70-year-old comes in and says, I want a COVID booster and a flu, bang, you can do both at the same time, okay? If they don't really want to do that, they say, look, I just want to do one at a time, then the next question will be, when do I come back? Okay. And usually what happens with the COVID and the flu side effects is that they're usually in the first 3 days, okay? And I'll show you some MOSVAC safety data, but the usual side effects are the sort of same things that we're seeing with the primary series, some red sore arms, some fever, some headache, some muscle and joint aches, and it's usually in the first 72 hours. So you might say, look, if you don't want to do them today at the same time, come back in, say, a week, and I'd probably, to be honest, prioritise the flu first right now, because they've already had a couple of COVID shots before. But if they wanted to do it at the same time, that's okay. If you've had COVID infection and then have the flu vaccine, okay, so this may be an issue. Look, but the usual thing with this is, like any vaccine, if they turn up in the clinic and they're well, they've recovered from their recent infection, it's fine to give them the vaccine. If, however, they say, look, I'm still not quite right, I've still got a bit of fever and cough, etc., I'd wait till they'd recover from that before I gave them the vaccine. This is a summary booster doses for the kids. As I said, under 5s, no booster. 5 to 11s without risk factors, no booster. 12 to 17s without risk factors, no booster. And then 5 to 11s who have risk factors, because of the age registration, you have to give them the original strain as the booster. Yep. But for the 12 and over, it's registered for 12, you can give them the bivalent BA45 booster. Both of them if it's been more than 6 months. So that's the summary for you, is that severe disease, they work pretty well, particularly in the over 65s, but it does not last years, like we've shown you, the up and down, okay? Symptomatic disease bumps up for one or 2 months and then quickly falls. Under 65s, you know, it sort of does march up a little bit as you get towards 65, but it's not just suddenly a magic change at 65, okay? So Targhi's made this word that under 65s of considerate, okay? And maybe at the end, which sort of I'm about to finish the COVID one soon, we can have a chat about what that means. Yeah, so the risk of a severe adverse event is pretty low. So as you know, there have been stories certainly with the first 2 doses, and particularly the second dose with the mRNA vaccines for the myocarditis and the pericarditis. That doesn't appear to be increasing with each booster dose, if that makes sense. So it's, dose 1 is lower, dose 2 is higher, dose 3 or booster 1, booster 2, it steps back down again. So if someone's not had myocarditis in their primary series or pericarditis, then they're unlikely to get it with their booster dose. Never say never, but it's unlikely, okay? We're not seeing any other real significant at the moment safety concerns with the booster dose. There was, you may have read about in the press, a risk of strokes. I don't know if you saw any of that. The Americans, so what happens when we do these particular vaccine programs is that there's very active safety surveillance systems in many of the countries. And the Americans do these really nice data linkage studies where they can marry receipt of a vaccine with admission to hospital. And they can look at admission to hospital for diabetes or for a stroke or for a pulmonary embolus. And they did find early on with the booster doses a little bit of an increased risk of stroke in those that had flu and COVID at the same time. But as we've got more data, that risk has disappeared. So it was what we call a safety signal. It was originally flagged, but it doesn't appear to be continuing as we've got more data in. So it's just being watched. So no real safety concerns with the booster doses over and above the primary course. So that's all I was going to say about COVID. Happy to take some questions. Any? Yeah.
So is that still the go? Or?
So the question was, if you had COVID vaccine. Yep. Yeah. I don't think it's a hard and fast rule. So you know, it's a little bit. I probably would wait a week, but you can wait 2 weeks. It's just that I probably would get the flu in, like I said, and then if they said, look, the side effects are going to happen the next week. There's not going to be a response and interference with the immune response. It's more a safety sort of thing, really. So you could wait a week, but if they all said, look, actually suits me to come back in 2 weeks, that's also fine. So the minimum gap, you know, there's no minimum, but again, if they don't want to have it on the same day, but they want to have it 2 days apart for some reason, they can do that as well. Yeah. Yeah. Yeah.
No? Yep. One behind you. I've got this one here.
Okay, thank you. The booster recommendations, are they based on the data that's saying that majority of the population has already had natural illness? Is that why there's not that sort of push for those of us that work in health?
Pretty much, yeah. It's based on the concept, which if I go back to with the slide that I actually jumped over, this one, it'll be very hard to read from the back, but what they're doing in this one is that the panel A on the far left is just people that have had infection. The panel B is people that have had infection and vaccine. And then the panel C is people that have had infection, vaccine and a booster. Okay? Is that making sense?
Yep.
And the top bit is the bit against hospitalisation. And what you can see is that panel C, hybrid immunity, or hybrid immunity with a primary series, the line's pretty straight, okay? And the bottom thing is time since vaccination. So that suggests that primary series plus infection, the line's straight, so you still get good protection out to around about 4 or 6 months from just them having 2 doses and infection. So that's what's sort of driving a lot of the booster recommendations.
So if someone, say, works in health and we know from serological results that they haven't had like an illness, that'd be recommended to have the
Yeah, I think there would be no harm in... Also, the thing with serology is it also wanes with time. So you can see that the previous infection one, the graph just slowly decreases. That's because, unfortunately, the antibodies you get from your natural infection don't last forever. So antibodies do wane with time anyway. So if you're a healthcare worker, you don't think you've had COVID and your antibody, you've done a blood test and it says you've not got nuclear capsid antibody, could be because you might have had it and the anti-capsid antibody's gone,
yep.
Or you really haven't been you've been those lucky people in the community that's not had it, then a booster probably is not a bad idea. But we're not using serology to drive
yep.
the decision.
Okay.
So you don't go saying, oh, we'll do a blood test. If you've got antibody, we don't want to do that.
Okay.
Because we don't really know what the best antibody level is, to be honest. We know for tetanus, for example, if you're above this level, yeah, great, you've got good protection. But we don't have that for COVID.
Okay, thank you.
Yep. Any other COVID? What's happening in the front line? Are people saying, no, I'm just sick of vaccines, I don't want any more of this?
We have one here, Nick.
I can probably answer that question. There's still plenty of demand, I think, particularly in the older population, and everyone else is just questioning, really, whether they should do it or not. The question I have is, are there any plans to move from the CVAS system into the New South Wales ordering system? So moving it from a federally administrated situation to just how we order all of our flu shots and all of our other NIP vaccines?
I don't know the answer to that. I don't know whether Priscilla or Belinda does. Yeah.
Hooray! Thanks.
Hello. Oh, yes. Yes, they're definitely piloting that in some areas. And, yeah, I think once we get away from multi-dose vials, that all COVID vaccines will come through your vaccine centre. So that is very good news. But yeah, probably not this year, unfortunately.
I just wondered if we have to still keep doing the weekly reports and how long that might go on for.
I think while we're on CVAS, reporting will remain. But yes, I hope it disappears once a transition is away from that Commonwealth model. No promises though.
Any other COVID?
There's a couple
Yep.
here on slide.
The Slido ones, okay. There's one over here too.
Yeah, take that one over there. Yeah.
Do you want to yell out and I'll repeat it? Oh.
Hello. I had a mum come in and ask me a question and I didn't know how to answer it. So the mum had a small baby and she had had COVID when she was pregnant and she just wanted to know, does that mean my baby has immunity for COVID for a while or at all? And I said, I don't know.
So the answer to that comes from this bit here. Whoops. So this is what I was sort of saying. You can see in that 0 to 6 months, the red dot is the spike antibody, and that's from vaccine. So because we're not vaccinating babies under 6 months, that 90% is because mum had a vaccine during pregnancy or just prior to pregnancy. Or the infection is the blue one. So the blue one is probably 30% or so, nearly 40% of babies born today have got antibody from infection because their mother has had the infection. So that antibody will give them some protection. The 6 to 12 months, it jumps up, and that's probably because they've been on the planet for 6 months, so they've probably had natural exposure, natural infection. So what we do know is that the young babies, the under 6-month-olds, when they get COVID at the kids' hospital, when they come into ED at the kids' hospital, some of them are not too sick. But where we do see the problems is they have COVID and RSV. So they have these co-infections. And because they're 2 months of age, they have a cough and fever, they get an NPA, they get swabbed, they have COVID and flu, they usually end up with someone putting them in IV antibiotics and a chest x-ray, and admitted for 48 hours. That's sort of how it goes. Sometimes they just have a fever with no real focus, and the clinicians are worried that they're missing a urine infection or a meningitis, so they end up with a full septic workup. So that's the sort of problem with in the young babies. But as I showed you before, in the deaths, there are basically no, very, essentially 0 deaths. I'm going to have to go back through all this. Oops, I've gone the other way. Anyway, in terms of deaths, there are very few deaths in the under 6 months. Yeah.
Okay, so just a few quick questions here from Slido. Is there a limit to how many COVID vaccines an immunised compromised adult who is travelling can have, particularly if it's been 6 months since the last dose?
Yeah, I don't think there's a limit as far as we know. And as we've seen, is that the vaccines have slightly evolved to chase the variants. So the BA.4/5 booster gives you better boost. When they do the vaccine trials and the studies, they actually measure the antibody to each of those subvariants and see how well it neutralises the real virus, the variant viruses. So that is actually, it's a little bit like the flu shot. Each year we change the flu composition, which I'll show you in a minute. I suspect what this will happen is it'll settle into an annual booster. And it might well be the variant that's circulating a bit like with flu. So the Americans have moved just to a single bivalent booster for everyone pretty much as an annual event. And even if you've never had any course before, they just get 1 shot of a bivalent. And that's probably where we might head, but not right now. Yeah.
Perfect, thank you. Just another one following on from babies. Do antibodies from the vaccine transfer through breast milk? Do we know?
Not very well, no. Okay. It's an IgA antibody that comes out in the breast milk, yep. So it's not really protective.
Okay. And one last quick one. If you have reactions from one brand of vax, should you change to another option? And will reactions get worse with continued use of the same vaccine?
It sort of depends on what this is a good old academic answer. It depends. It depends on what the reaction is, to be honest. So if it's red sore arm, yes, changing brands may not make much difference. But if it's sort of a myocarditis or a pericarditis, then possibly it will. But AstraZeneca is sort of gone. It's no longer available, pretty much. Nuvaxovid, which is the Novavax one, not much of it being used in Australia compared to the Pfizer and Moderna, but it has a small risk of pericarditis, myocarditis as well. So, it really depends on what the reaction was, unfortunately. So hard to answer that one.
Okay. Thank you.
All right. We'll move on to flu. Okay, so how did the Northern Hemisphere fare from flu just gone? You can see the 2022 story, because remember their flu season is sort of pretty much October through to February, opposite to us. Okay, they had a bigger year in just gone. Most of it was flu A, some B Victoria, but basically no B Yamagata. Okay, so the vaccine has flu A and flu B components to it, but no B Yamagata. This is Canada, and what we're showing you there is the grey sort of, it looks a bit like a strip, is the period from sort of 2014-15. The very dotted line is the weird, unusual year of 21-22, and that's sort of, you can see that it was well out of season, and that's because of all of the measures that we were taking to reduce COVID. But the dark line is their season just gone, and what you can see was that it was back to sort of the normal amount, but came a little bit earlier, okay? So that's the Canadian season. This is Australia. This is lab-confirmed flu. Again, the bottom line there is the green one, which is 2019. Where is it? 2022 was yellow. You can just make it out. Pretty much not much flu at all. The red is this year. Started off early, dipped a bit, but now climbing. It might well end up again going back to what we sort of traditionally have, which is that black line, okay? You can sort of see the double peak. Don't quite know why it does that, but it's a common phenomenon with it. And most of ours are flu A, so 77% of them are flu A as well. This is influenza notifications in New South Wales. There's a lovely report which you've got the link there. New South Wales Health puts out sort of the COVID flu and all the other viruses. You can actually look at them fairly regularly. You can see it's just slowly trending up from about early March, mid-March. Flu Tracking is a group from Hunter, New England that survey people to look at their flu-like symptoms, and you can see that it's sort of started up again as well in the black. This is by age, and the top two lines are the 0 to 4s in red, and the, what is it? I don't know what that colour is really, yellowy colour, is 5 to 16s. And just struck me before when I was looking at it that you can see it dipped, and then it, from about 24th of April, it just started to take off. What do you think that coincided with? Yeah, going back to school. So these are the engine room of driving community transmission. Kids get into classes, spread, cough and sneeze on each other, take it home, take it to Coles and Woolies, and away it goes. Okay. The other groups, not much there, but mainly the younger kids, the 5 to 16. So this is coverage. We did really well in 2020, and this is by May May 14, you can see at 2020 we had in the 6 months to 5-year-olds, we had about 30% already vaccinated. It was pretty good. I think that was, early COVID days. The red line is how we're tracking at the moment in the 6 months to 5 years, around about 10%. So remember, that's the age group for whom the vaccine is free. Okay. In the over 65s, you can see the red is climbing up, similar to other years. So as of around about now, we're sort of at the 45-50% mark. Okay. So that's we want to get that younger kids up. I heard someone ask earlier about would you do the flu vaccine in primary schools? You could argue that it's not a bad idea when you see that uptake, but logistically, all the consenting issues, that would just be a huge ask. It might be worth someone doing a pilot on or something. But how effective is the flu vaccine? So this is data from last year. If someone says to you, oh, this vaccine is rubbish, it doesn't work, we can say, well, it's only half rubbish. Last year prevented hospitalisations by about 50%, okay? And hospitalisations is a good thing to prevent. Because of time off work, people having to look after, while you're in hospital, etc. And the other thing that was quite good last year was that across the different age groups, the flu vaccine was fairly similar. Even in the 65s and above, who were giving that special vaccine, remember, the adjuvanted vaccine, it was still around about 50% effective. So that's what happened last year. This is the vaccine for this year. Has 2 A's and 2 B's in it, okay? That's your usual quadrivalent story. This is the recommended age groups, which you all know, so we won't dwell on it too much. But there's always this query on, I know that vaccine protection only lasts 3 to 4 months, so you know what, I'm going to wait till it's May the 31st, and then I'm going to get it because I can get through to August by then. I wouldn't think like that because, as I showed you, it's here now, okay? So don't just say if they're here, we want to get it in. Like we talked about before, you can give it with COVID. Fluad Quad, which I'll show you in a second, and Shingrix, they haven't really been given together much in the way of studies. So if there's really your only opportunity to get the person to get both, you can do it. But the recommendation is actually to separate it probably by about a week again, okay? And we always get this question, I had the flu vaccine late last year, do I need it again this year? And the answer is yes, because it's a different updated strain. And I showed you before that we had the new strain for 2023, okay? So that's just some additional thoughts there. Eligibility under the NIP, over 65s, and then these other age groups. This is all known to you, so we won't go over it in detail. Pregnancy at any stage during pregnancy. In the white boxes are the ones that are free under the NIP, okay? Over 65s, there's Fluad Quad, but if you don't have that and you've got the high dose one, you can use that as well. The thing about the over 65s is they need, which we sort of say each time, the immune response needs a little bit more of a tickle up. So that's why they put the adjuvant in the vaccine. The adjuvant says, this is foreign, this is not quite right, sends all the immune cells there. When they get there, they think, there's flu antigen, I'll make flu antibody. Okay, that's one approach. The other approach is to stick more antigen in, and that's what the high dose one is. Got extra amount of antigen compared to the normal vaccine. How did it go in the Northern Hemisphere, the effectiveness? So this is data from just the season gone past in the US with the same vaccine. Effectiveness also around about that 50 to 60% mark. Okay, so if we're the same, we should hopefully see the same effectiveness this year. Often we get asked, what about the cell-based vaccine versus the standard vaccines? If you really want to dive into it, there's a lot of information in the NCS website. but both vaccines have similar efficacy and effectiveness, so it's the cell-based one rather than the one that's grown on the egg culture, but it's not on the NIP. Okay. Some of the usual questions, can it be given to those that are latex allergy? Yes, they're all latex-free. Egg allergy, we've given thousands of people over the years who have egg anaphylaxis to flu vaccines, and it's fine, we can do it. Co-administration, I talked about Shingrix, additional doses, so sometimes we think, people say, well, it's now October, November, and I'm going to the Northern Hemisphere for 6 weeks holiday, and I can't get the Northern Hemisphere vaccine. Should I get a top-up with the Southern Hemisphere one? And yes, you can. I'm not sure how people have looked at how effective that is, but you can do it. So that's an idea, and there's a flow chart there about Guillain-Barré syndrome, which we won't go into. So this is Mrs. Smith. She's 25 weeks pregnant. She's had antenatal screening, which says she's rubella non-immune. She had last Boostrix 3 years ago, and she did have PCR positive COVID 2 months ago. So which of these four vaccines, would you like to give her? So influenza, yep. And pertussis. And we probably wouldn't give her rubella because that's the live attenuated vaccine and we don't want to give that to a pregnant woman. And the COVID, she's had the recent infection 2 months ago. Okay, so she really only needs Boostrix and flu. Yep. Ausvac safety. So this is data as of, 10 days ago. There's a lot of information on Ausvac safety, and I'll talk about it after lunch and how we do this surveillance. But what you can do, I think if people are particularly interested and they want to, find out how safe the vaccine is, this is data that rolls in each week from around the country, and we put it up on the website. And you can see from this year, we've already got nearly 140,000 people who've completed surveys from around the country. Very, very few are reporting any sort of adverse event, and that we then break it down by age group. So not so many in the under fives, but nearly 3,000 surveys. And we ask for local reactions, fatigue, etc. You might recall that there was the issue, 2010, with the flu vaccine and the fever. So we do look at fever each year, and we want to make sure we're not missing a febrile seizure type story again. About 10% of parents are reporting their kid did get a fever. Now, whether that's because of the vaccine or because they, whilst waiting to get the vaccine, they got exposed to a virus in the surgery, hard to know. But 10%, which is in the usual ballpark of what we see every year with the flu vaccine. Okay, so there's no concerns. This is all very similar to previous years. Even less survey in pregnant women, but again, very good safety profile. Same as every other year. And if you went onto the website, you can look at the over 65s, etc. as well. Okay. In terms of, just to finish off with another virus, RSV, and the reason I bring it up is that when we come back next year, we can probably talk to you about the vaccine. So RSV is a virus that does cause respiratory infections. Again, if you tested us, we've probably all had it, particularly as we work in a healthcare environment, and it really only causes problems for the very young and the very old, okay? No specific treatment for it. When we see kids in the hospital with it, we just give them supportive treatment, sometimes some oxygen and antipyretics. You probably won't be able to read it from the back, but the top panel is the kids sort of up to the age of, I think it's about 12 months, if I read correctly, to 2 years. The top blue line is the 0 to 2 months, and then the red line is 3 to 5 months, 6 to 11, and 12 to 23. So, and the x-axis says admissions to hospital. The x-axis, you may know the difference, that's in thousands, okay? It goes up by thousands. The bottom line goes up by 5 and 10s. But you can see the purple line that goes up, that's the over 65s. So a lot of disease, fair bit of disease in the over 65s, but nowhere near as much in the under 2s, okay? And it's probably gone up a lot in the over 65s because now we've got all these swabs we can test it for, okay? So in the past, we probably weren't testing the adults when they came in with their cough and runny nose. We were just, oh, it's probably a virus, probably RSV, but we weren't testing. So the targets for the drug companies to think, there's a burden of disease here. I want to vaccinate the younger kids, the under 2s, and the over 65s, okay? So that's what they do. They're going out and making vaccines against RSV, all right? Trials have been conducted in adults. Because it's easier to do trials in adults compared to young kids, they did first of all in the adults, and yet the US has just approved an RSV vaccine for the over 60s. So the over 60s might get a flu, a Shingrix, a Boostrix, a COVID and an RSV. So we're all going to have a job for the future. And that might be an annual, Boostrix won't be annual, but flu, COVID and RSV might well be an annual event, okay? And then there'll be all these sorts of questions. Do you give them at the same time or separately? If you don't give them, do they interfere with each other? So all these studies are yet to be done. But it's not far off the mark, okay? So when we come back next time, we might be talking to you about the new RSV vaccine that's registered for Australia. Okay, so my message really is to do winter well, okay? And that's giving a flu, thinking about a COVID booster, a pneumococcal booster, which I'll talk to you after lunch. And obviously you know about reporting vaccines, so I don't need to say anything more with that. So that's the story for flu. I'm just going to... What have we got? Time... Oh, there's still a bit of time for lunch. Got to do JE and Murray in 20 minutes or so. Any questions with flu? Yeah. No, can you use the antivirals for COVID for flu and RSV? No, don't work. There's oseltamivir, Tamiflu for flu. There is not much in the way of RSV antivirals, but the Tamiflu, oseltamivir. So there will be, I don't know whether public health, but there are guidelines around the use of oseltamivir in aged care facilities and that sort of thing. Yeah. For flu. Any other flu questions?
Just a couple from Slido, Nick.
Yeah.
Should we be giving the flu vaccine right up until the expiry date of the vaccine, or stop offering after the end of the flu season?
Oh no, I think if they've not had it yet, does that mean?
So can we keep vaccinating
that's fine,
to the end of December?
As long as it's not expired, yeah.
A question here about wondering why, or suggesting free flu vaccines for 5 to 17-year-old age group due to high rates in this age group?
Yeah, it's a good question. I think it has to go through the PBAC assessment, the health benefit, the cost benefit assessment. Yeah. I don't know if the companies are putting up for that sort of assessment yet. Okay. I know that a lot of the free flu programs for the under 5s were started and funded by state health departments before it got that, before the Commonwealth put it. And you'll see this afternoon that it's actually, what's nice now is New South Wales Health Schedule actually has flu on the side of it, so it looks like it's part of the routine program, which is really good.
And one last one here on Slido is, if you have had Botox, how long should you have to wait before you have a flu vaccine?
As far as I'm aware, no. This is Botox for, let's say, cosmetic reasons or for therapeutic reasons.
Doesn't specify either.
Yeah, no, as far as I'm aware, there's no real although no real difference. We were hearing people that had lip fillers, though, with COVID, getting a swelling of their lip, though, which was a bit weird, I thought. But there was definitely reports. And it might have been something to do with the polyethylene glycol that is put in here. It's also in the vaccine. So anyway, that was what we were hearing on the grapevine, that their lips got... Yeah. Any other COVID?
Questions?
All right, and don't want to keep you from lunch, so JE. So JE is one of the... There's two different sorts of viruses, or there's many different sorts of viruses, but two groups is flaviviruses and alphaviruses. So flaviviruses, the one we're particularly talking about is a mosquito vector-borne one, so Japanese encephalitis and Murray Valley. They can cause very severe disease, and I'll show you some sort of stories about those. So JE are mosquito-borne, as you know, out this way from sort of Narromine, Dubbo, etc., and further west. Associated with pigs and water birds. It can cause disease in humans, and pigs are an important part, and that's why there's a lot of the work done around the abattoirs, okay? And the abattoirs and the piggeries. So pigs are an amplifying host, so the mosquito bites the pig, the virus amplifies, gets more of it, mosquito then bites the pig again, and then can go and bite humans. It can cause a very nasty encephalitis. So this is sort of the life cycle. There's the birds and the mosquitoes, okay? The pig's sort of this amplifying host. Mosquito can bite the human, and then we can get Japanese encephalitis. And that's probably the reason that it's sort of come down to Australia is probably climate-induced. More water, particularly with La Nina, movement of the mosquitoes, and so you know more than I do living out in the bush, but I know there has been a fair few mosquitoes earlier in the year. I don't know if it was like out here, but certainly down on the Murray River, people were talking about lots of mozzies. The other thing to say is that, so pigs are important, and we sort of know where the piggeries are because we know where the localities, but the other thing we also know is that there's a whole lot of feral pigs, and the feral pigs can also be amplifying hosts, okay? And this is just a density map showing didn't come across it except I was researching this website called Feral Pig Scan. But anyway, the red is where all the feral pigs have been spotted, okay? This is the mosquito, the Culex aniliorostris. It has come down from the north because most of the JE endemic areas were Southeast Asia, okay? And we had some cases in the top tropical part of Queensland and the Torres Strait, but really nothing below the sort of Queensland border until last year, okay? Good thing about the mozzies is they don't go too far from the larval habitats, okay? Feral pigs I talked about. So that red line is New South Wales, and they're the LGAs of high concern and pretty west of the mountains, really. And so this is a case which was written up in the Journal of Paediatric Infectious Diseases journal. This is a 10-year-old, Murray River area, fever, vomiting, headache, and a very low coma score of about 10, and was actually at the peripheral hospital because of hypoxia and low level of consciousness, was intubated and transferred to a paediatric ICU in Melbourne. This is the sort of, they basically looked for different viruses. They did find on serology that the child was positive for Japanese encephalitis, okay? This is just not to scare you, but to show the extent of what this can do. This is slices from an MRI. When you see an MRI on a slide, always look for the arrows because they're the important bits that are pointing to parts of the brain where there was inflammation. this is not the kid, but they get this mask-like stare, like a Parkinsonian rigidity with the encephalitis. This poor kid ended up with steroids, immunoglobulin, and tracheostomy, okay, to help with the breathing. Had total parenteral nutrition, got better, but had a long period in hospital for rehabilitation. So it can be quite nasty. So, but having said that, most of the infections are asymptomatic, all right? And severe disease is in less than 1%. So unfortunately, that kid was in a very less than 1%, but still quite nasty. The usual symptoms are headache, fever, muscle aches, neck stiffness, so that's sort of encephalitic type problem. Who should be vaccinated? So you need to check, and we'll talk to you about the New South Wales part, but it's not part of the national program. ATAGI does have recommendations, and vaccination really is one of the strategies, as well as trying to avoid getting mozzie bites, okay? So you probably can't read it, but the box there talks about the LGAs of high JEV concern, and Priscilla might want to talk about it, but you've got, Narromine, you've got Parkes, Dubbo, Gilgandra, Warren, what other ones are out here? Barorona, Burke, Broken Hill. So they're the ones for which there is the program available. If you live in an LGA and you work outdoors, or you've got these other things here, then you should get the JEV vaccine. Okay. There are two sorts of vaccines. I think as part of the program they're using Imugev. It's good thing about Imugev is it's just a single dose, okay? The bad things about Imugev is that it's a live attenuated vaccine, which means you can't give it to people that are immune suppressed or pregnant because it's a live attenuated vaccine. Yep, okay. Gespect is the other one. It's got a 2-dose schedule, but it's an inactivated vaccine, which means we can give it to those that are pregnant or very young or immunosuppressed, okay? Booster doses. I think I've got a slide which talks about the booster doses, so I'll jump over this one. If you do get the Imugev vaccine, then we tell people to try and avoid pregnancy for 28 days. Because it's live attenuated, if they have immunoglobulins or blood transfusions, that can interfere with the response. So like any live attenuated vaccine won't have an interval. If you're going to give it with another MMR, another live vaccine like MMR, either on the same day or 1 month apart, okay? So that's that one. Gespect we can use with immune suppressed. And the ATAGI's got some notes there about using it in the very young as well. Here's the summary, yeah. So booster doses for Imugev, if they're over 18, they don't really need a booster dose, okay? If they're under 18 and they've got Imugev, single dose, but you can give another booster if there's ongoing risk of exposure. So we'll have to work out what we've done with the kids in the LGAs, whether we do offer them a booster down the track, depending on what happens with JEV. I talked about that one. It's a fairly safe vaccine. Usual sort of side effects, injection site pain, redness, headache, fatigue, malaise. Children can get fever, appetite loss, irritability. We are doing a study with the ministry, with the Murrumbidgee Local Health District, and what we're doing is randomising people in Young and Cootamundra to get either subcutaneous injection or intradermal. And the reason that we're doing intradermal is because if we run short of vaccine, for each vial, which is 0.5 ml, we can get 4 people vaccinated, 4 or 5, because it's only a 0.1 intradermal. So if we have a shortage of vaccine down the track, we'll have some evidence to say, yes, intradermal is a reasonable option, okay? And so that's why we're doing that particular study. Lots of resources out there about JE on health.newsouthwales and on the NC's website. And in the last couple of slides, just to talk to you, Murray Valley encephalitis obviously is caused by the Murray Valley encephalitis virus. No specific treatment for it. Again, trying to avoid mozzies. There's a nice web fact sheet there on New South Wales Health. What's interesting is that vaccination or potentially natural infection may actually give you partial protection against Murray Valley. Okay? There's not a lot of human evidence on this, but because they're the same flavivirus, there might well be some partial protection. So getting a JE vaccine may well give you some Murray Valley, but don't walk out of here thinking, I'm going to get the JE vaccine because I'm protected against Murray Valley, but we don't have enough info. But when they've done animal studies, they've given the animals a JEV vaccine and then actually challenged them with Murray Valley, and they've actually done some protection. So it's possible. So we are looking at trying to look at that particular cross protection in the study that we're doing at the moment. So that's an interesting thought. So that's pretty much it from me. Whoops, that's the next bit. Happy to take any questions before lunch. We're on time.
It's working. Yeah. One on Slido, Nick. Can Q fever vaccine be given with the JE vaccination, or if not, what interval would you recommend?
So, because it's there's actually not much in the handbook to guide that. I think probably, if it's your only opportunity, you probably could give it at the same time. But probably the best thing to do is to separate them by a couple of weeks, would be my advice. Depending on which one they need more for their work or whatever, is how I would decide which one to give first. But I probably would just separate them by a minimum of 2 weeks. So the Japanese encephalitis side effects are usually in the first 5 to 10 days. And so, 2 weeks later, they should be over any side effects from the Japanese encephalitis one, and then you can go. Remember the Q fever one, we're going to do the blood test and the skin test beforehand as well. But separate them by a couple of weeks, probably even a month would be reasonable. Any other JE?
I've got a flu one here that I forgot to ask earlier,
Yep.
if that's okay.
Yep.
Has there been any talk about Australia getting a nasal delivery flu vaccine like in the UK?
Yeah, there's talk about it. This is the flu mist. So it's a squirt up the nose, live attenuated nasal flu vaccine, used in the US. I don't know where it's at in terms of TGA submissions and the target, but I definitely know that it's hovering around a bit. Yeah. There's lots of work being done on nasal COVID vaccines, and there's also being work done on skin patch flu and COVID vaccines as well. A bit like the nicotine patch that you whack on, but it's got COVID and flu in it. Is it? Yep.
Thank you, Nick. Yeah, round of applause. That was very insightful. Okay. Show of hands, any wild pig hunters here? See me after lunch. Yeah, quite obvious why it's so popular. Now, I'm on good authority from the team at the PHN that, look, a copy of the slides will be sent to all attendees present or not. So don't stress, you will be you'll be able to get a closer look at all those graphs and statistics, so look out for that in your inbox the next couple of days. We do have, you saw it very briefly there, we do have another word cloud. So what words best describe what you love about the team that you work with? And we know the nurses are stars of that team, so feel free to let your words fly. Don't forget to submit questions too via Slido. You heard Katie reading them out, so we are looking at them very closely. And obviously, please say hello, speak to our sponsors and the resource plays at the back in between conversations and lunch. On that note, please, food is waiting in the green room area. We will reconvene around 1:10, and so we'll call you in about 5 minutes early, where Nick will join us again at 1:15. Enjoy. Okay. We'll kick things off. So to start the second half of today's activities, we're going to welcome back Nick for this afternoon's program. And he's going to kick us off with a whole-of-life vaccination update. So Nick, if I could ask you to rejoin us here at the rostrum. Thank you.
Okay, thanks very much. So that we don't all fall asleep in the next hour after lunch, I'm quite keen to make this, I think it goes to about 2, so just over an hour, an hour and a quarter. Make it very interactive. So again, I'll pause after different bits throughout the talk so that you can think of questions and we can have a good discussion. So I suppose the first thing just to remind people, which I had to remind myself when putting the talk together, was you guys at the front line seeing people and giving vaccines, that is just to remind about the halo principle. So thinking about the person in front of you, their health, age, lifestyle, occupation, is there anything that triggers them to need extra vaccines? And we'll talk about that as we go through the scenarios. I suppose the other reminder is don't forget the routine. We have seen a little bit of a slide in coverage globally for things like measles, mumps, rubella, DTP because of COVID. Harder for people to get to the doctor. And the same thing is happening a little bit in Australia, and we don't want to see that slight dip continue. So that's the routine. So don't forget the routine was the message. And the reason for that is that we are seeing things that we don't really often see. Tetanus. So there was a tetanus death recently in the north of New South Wales. Haven't seen that for ages. Polio, some polio cases around. And as you also know, we've had measles. So there's been a couple of measles cases in Western Sydney. I think, whoops, so I thought I had a slide there. There was actually a case in Queensland as well. This particular baby that had measles, I think 6 or 8 months of age, so too young to be vaccinated, but had got it overseas, had come back to Australia, sat in the emergency department at Kids Hospital for about 3 hours, and then eventually someone said, that's measles, and it was confirmed. And that then led to an enormous contact tracing process. Everyone that had contact with that baby, everyone, the parents and the other kids that were sitting in the waiting room, such that in the week following, the Public Health Unit at Western Sydney and Kids Hospital ran a vaccine clinic to basically give emergency MMR boosters to those that had not been vaccinated. So just a reminder, which you're doing, because I think I was asking Priscilla earlier, your coverage in West and Far West is really high, but we just got to maintain that. So in terms of why we need to keep coming back each year is because we keep changing the schedule. So as you know, HPV, now a single dose. The optimal age is at 12 to 13, which is why it's been given in the school program, single dose prior to sexual exposure, prior to obviously getting exposed to the HPV virus. If you've not had that HPV vaccine by the age of 14, you can still get the vaccine up to the age of 25, but earlier in adolescence, prior to any exposure, is the best. Okay. It's one dose, as you heard earlier. However, if you're immune compromised, just because of the immune suppression that you have on board, it means that the vaccine antibody levels don't work as well, so you just need extra doses. Okay, so they need to have 3 doses. That's no change. Men who have sex with men of any age are recommended to have it, and the number really depends on the age. We often get asked this question about those over the age of 26. So not routinely recommended to have it, but they may benefit from it. And it says there the schedule over the age of 26 is 3 doses, and you can see the intervals there between it. It's always sort of puzzled me why we can get away with 1 dose, 12 to 13s, but as you get older you need 3 doses. And to be honest, probably 1 dose would be okay, but the way that it happens is what's submitted for licensure and registration to the TGA, etc. And if they put forward evidence that a single dose at 26 is probably okay, then that might change it. But it's all based about what the companies put up to the TGA, etc., if that makes sense. It's the same idea with the hepatitis B vaccine. 2 doses between 11 and 14, 3 doses either side, and that's purely because what's been put up to the company to the TGA, if that makes sense. Yep. So we talked about HPV. For you guys, the good news is it's 1 less to give, or for the school program particularly, one dose less to give. There is another new vaccine coming to town. Have you heard about this one? Anyone heard of Vaccination? Yes, no? Sounds like a no. Okay. So Vaccination is like Hexa, Infinrix Hexa. It has 5, so you've got DTPA, so it's the 6-in-1. Obviously Hexa is 6, hexagon, etc. This is also 6-in-1. Slightly different in that the pertussis component has 5 bits of the pertussis bug in it. So they've got 2 extra antigens in it. And the other thing that's probably in this vaccine is there's no need to reconstitute it. With Hexa, you've got that Hib pellet. You're all putting the Hib pellet in. This doesn't have that, okay, so there's no need to reconstitute it. BBAC recommended it for inclusion on the NIP. How the supply-wise and what a target was still to come, but it gives us another infant pertussis-containing combination vaccine. In terms of studies on that one, there has been a trial done. This is the paper in paediatric infectious diseases. What they do in these particular trials is they do what's called non-inferiority. So they have to show at least that vaccine A is non-inferior or equivalent to vaccine B. And they have to show that it's equivalent in terms of safety, but also in terms of antibody responses. If it meets that non-inferiority, then it's, could be licensed or registered at least. In this trial, you can see what they do is they have to measure antibodies to all of these components, the PRP, which is the Hib, the diphtheria, the tetanus, the polio 1, polio 2, polio 3, and hepatitis B, etc. And they measure the vaccine of study, Vaccination, and compare that to a control. And the non-inferiority was met. So this is the data that the company puts together to submit to TGA, who then, like I said here, has been PBAC has looked at it, and it's going to be probably put on the NIP. But supply-wise, I'm not quite sure, unless any of the companies at the back know. The other one that's changing is Shingrix. Okay, Shingrix was recommended by the PBAC in March at the age of 70. Okay. Aboriginal and Torres Strait Islander adults over the age of 50 and above, and those at high risk of herpes zoster. The current catch-up program for Zostavax finishes on the 31st of October. So Shingrix is a 2-dose schedule. Okay. The important bit is that it's at 70. Yep. So it's not either side of that. It's on the program at 70 for the year of their 70. So if they get to 72, it's fork out the wallet. Yep. So if you can remind folk about the 71. I think of the note, Michelle, are you still happy to do this? So you can see, I think Lauren wrote this, and so I just wanted to check before you agree to it. Michelle can help you try and identify a patient. There might be, mail outs to say you're 70, Shingrix is available. The good thing about Shingrix is that it can be used, don't have to think about immune suppression, okay? Because that has caused us a few issues with Zostavax in the past, so that's good. So just, if that wasn't enough, with some new pneumococcal vaccines in town, there is a new 15, so as you know, we've got two vaccines really. There's Prevnar 13, which is the 13-valent, and there's the 23-valent Pneumovax. They're moving more towards higher valency conjugate vaccines, okay? So there's one called Vaccination, which is a 15-valent vaccine. And then there was also Prevnar 20, which is registered for use in adults over the age of 18. I was just talking to the team at the back, and it seems like Prevnar 20 would be coming into the country fairly soon. So what we are doing is waiting. The schedule will probably change a little bit. What might happen is that they put, as I think I've got it in the next slide, how we use Pneumovax 23 might change a little bit. So this is Vaccination, 15 valent. The little red boxes show you the 2 extra pneumococcal valencies that are in it compared to the Prevnar 13. What might happen is that it's used, this is what the PBA said, that 15 valent can be used in non-Indigenous adults over the age of 70, Aboriginal and Torres Strait Islander over 50, and those at increased risk of pneumococcal disease. So it might, and I think the handbook at the moment says this, either can be given 13 or 15 valent. It's really a supply issue for that one, and then Prevnar 20, well, this might change, and I'm not predicting it, but this sentence might change that a single dose of 13 or 15 or 20 is available. So that's possibly the way it will go initially, but time will tell on that one. So just flagging that's in the pipeline. The other thing is that the handbook will slightly change, not a huge change really, but they're just looking at different wording for recommendation to recommend optional and not recommended, and so that's just a sort of minor thing. They're actually building in a new COVID-19 chapter. So at the moment, I don't know how you find it, but you've got to go. If you look up COVID-19 on the website, you get on Google, you get all these different pages. It'd be great to have one handbook chapter. So that's coming, and it should be online soon. And it will probably, obviously, because it's only online, it'll have to be updated and collated. Okay. So that's a little bit about some new changes coming. So we'll just do some scenarios, unless there are any questions on any of that. Yep. So the question was, if you had Zostavax and then when you turn 70 have Shingrix, yes, as long as it's 12 months after that Zostavax. Yep. Yep. You can do that, yep. It'll probably come out in the guidance. Okay, so this is scenario 1, and we'll just get you to yell out some ideas. 19-year-old Shelley and partner Jack, who's close to being 20, visited the practice because they're planning to start a family soon. And Shelley says, I might have some vaccines before conceiving and after the baby. Neither Shelley, Jack or their families identify as Aboriginal or Torres Strait Islander people. So, what would you like to discuss? First thing I would be saying is don't get pregnant just yet. I just wait a few years. Don't. You've got time. That's the first thing. But no, they're keen. So what do you want to say to them? How would you approach it? Yep. So someone said have a look at what they've already had. How would you do that? That's pretty easy, isn't it? Just are they that organised they've got their baby blue book with them, do you think? Nah. So air was definitely worth a look. So the things you want to think about is, yes, the previous vaccination history, and have a look on the air to do that. The need for the interval, I don't know how many people really hear when you say, look, I'm going to give you a live vaccine, don't get pregnant for the next month. I'm not sure. They walk out thinking, right, that's it, nothing for the, I don't know how they think about that. That the antibody that they will get from the booster, that will obviously check to help the baby. Think about the cocoon, the herd immunity, identify any underlying health conditions. Obviously, you don't need to probably go into the birth Hep B now, but think about additional meningococcal B. So, Shelley had completed a childhood immunisation schedule. However, she didn't get any varicella vaccine as it wasn't NIP funded. And she doesn't think she's had natural varicella. She did get the high school Boostrix, but she didn't get the HPV or the Men's C. Okay? Tom is up to date with his childhood. He had chickenpox as a kid, therefore he didn't get the vaccine. Tom also got Boostrix at school, but didn't have HPV or meningococcal C. So what would you like to do with Shelley? See if it's...
Hello. We also need to do an STI check on them.
What, sorry?
An STI check.
STI check. Yep, good point. Yep, I didn't put that in, but yep. STI check's a good idea. Yeah. So, Shelley, 2 doses of varicella vaccine. Now you might say, well, how many of us have had 2 doses of varicella vaccine? Although the handbook recommends it, it's actually only funded, as you know, for 1 dose at that 18-month as part of MMRV. Yep. Give her a MenACWY and HPV a single dose. So she can have it at 19. Yep. Jack needs a MenACWY and HPV, and ideally do that before he turns 20. So there are lots of resources to help with the catch-up story, which we won't go into, but we'll leave these slides with. And there's lots of information. I was looking at the table down there before, which is fantastic. Okay. Shelley now does get pregnant, despite your efforts. And she's come along with Mum, and she's 12 weeks pregnant. Shelley asks Shelley's mum says, why does she need to be immunised? And Shelley's mum also asks the need for the grandparents to have a booster dose. What do you want to tell them? Yep, so you're all going to give advice. The question, the comment at the front was evidence-based about flu and pertussis. That we had written that between the 2nd and 3rd trimester for pertussis. Now, that's again probably based on the idea that it's not too late in the pregnancy. So if someone turns up at 36 weeks gestation and says, damn, I missed my whooping cough booster, you can give it, But is it really going to benefit the newborn? Probably not so much. It's a bit too late. Because what happens, remember, is mum gets the vaccine. Mum's got to take a week or two for her own body to make antibody, and then a couple of weeks for that antibody to cross placenta into the baby. So you don't want to give it too late in the pregnancy, but if she's there and then and she says, I want my boostrix, great, give it to her. It might do something, but it's not really going to be the best. Most, I think, women like to sort of wait till they're in the second trimester. So that's also, so the sweet spot, if you like, probably is that second to third early third trimester. COVID we talked about before, if she's got additional risk factors and if it's been more than 6 months. So the other thing to talk about is that, as we talked just a minute ago, that placental antibody does go to baby. So baby starts life with some flu antibody and some whooping cough antibody. We don't like flu disease, although I notice New South Wales Health is now calling it influenza rather than flu, because flu is just, trying to make it more serious, influenza. It increases the risk if you're pregnant. And the pertussis vaccine is pretty damn effective in stopping whooping cough in young infants, upwards of 90%. That's pretty good. So you can, and we don't like whooping cough in babies under the age of 4 months because they get sick with it. So it's a good vaccine. And then you can talk about the cocoon idea, and if grandma is there and she's happy to get a booster, and we'll talk about that in a minute, but that's also good for a whooping cough boost for herself as well as tetanus. Again, there are lots of resources there in the handbook, which we can have a look at. And there's a nice section particularly for pregnancy resources. I haven't got time to go through it all, but have a look at in the handbook for those specific pregnancy resources. Okay, so this is a new family. We've left Shelley and Jack. They're off on their own now. So we've got 6-week-old Isaac and Sonia have come to your practice in Orange, because they've moved from South Australia. Isaac is was born at 38 weeks gestation and no complications. He's only got the birth Hep B, and both mum and Isaac identify as Aboriginal and Torres Strait Islander people, and Aboriginal, sorry. What would you like to offer to Isaac? So he's, what did we say, he's 6 weeks of age. So Sonia's stated that she's only had Hep B, but you probably want to check what maybe Isaac's had something on the air. So now that he's in New South Wales, you've got that pink New South Wales schedule up the back. Yep, so he's got to follow that. So we've got additional vaccines, okay, because they identify as Aboriginal people. So the meningococcal B program, which we'll talk about next, that's an important one. Influenza vaccine, once he turns 6 months of age. And because it's the first time, we ideally want to give him 2 doses in that first year. To be honest, I'm not sure how well we do that the first time kids get it, but that's the sort of rule. And what other adult vaccinations would you like to discuss, which we'll talk about in a minute too? So in terms of the schedule, I've just taken a snip from that purple one out the back there. You can see the meningococcal B at 6 weeks, an extra dose at 4 months. Although it's not on the schedule, I wish they had actually put pneumococcal B in the list of diseases and vaccines. Pneumococcal, not B, pneumococcal Prevnar 13. It's in the information section, but it probably would have been better to have had it in the diseases and the vaccine section. So additional doses of Bexsero. And what do we have to remember with Bexsero? Yeah, so prophylactic paracetamol before, 2 doses after. Sometimes people say, I really don't want my kid to have 3 needles and the oral rotavirus and Panadol all in the one sitting. And it's tough for you guys to give that, particularly in an infant. So you can split up Men B because it's, I think there's guidance in the handbook about where to give them on the leg or the thigh rather, because of the location of the, the injection site. But you can give all 3 injections and the oral rota all in the one go. Yep. With the prophylactic Panadol on board. So that's the 246 schedule, which you all know. And remember pneumococcal at 6 months. And then at 12 months, again, you've got that extra. So they've got 2+1 for Men B, the 2 primary doses, 4 months and then 12 months. The 18-month doses and then the 4-year-old doses. So can Bexsero be given in the same limb? Yep. So what we've sort of suggested, if you're going to give Bexsero and Prevnar on the same time, rather not give it in the same leg, just put them in different legs. Or if you do put it in the same leg, it's a bit hard to say an inch with a small thigh, but you can do your best. Don't put it in the same hole, I suppose is what I'm getting at. So try and separate it a little bit. At 12 months of age, it sounds weird to say this, but we want to give it in the upper arm, Bexsero, because they do cause some pain, and particularly when a 1-year-old's trying to walk, if they've got a sore leg, they don't like that. So it really depends on the kid, but you guys are experienced at doing that one. There is lots of Men B resources up the back there, which is great to have a look at. So can it be given at 6 weeks of age? Yes, we know that. Can be given at the same time. Children over the age of 2 eligible for the funded catch-up. That's correct, no. So you've got to get that in before the age of 2, okay? If a child had their first dose at 23 months, is the second dose still funded? Absolutely. So the comment is if you start that catch-up before 2, the second dose is funded. Yep. After 23. What did I miss? Oh, sorry, here. Oh, yes. I'm not sure what's going to happen beyond that, whether anyone in the PHU knows, LHD. I suspect it will continue on, but... where are we up to? Done that one, done that one. There you go. Wendy can help you. Michelle or Wendy can help you. Is that right, Michelle and Wendy? Okay. Well, we can get back to you on that one. Yep. Okay. So it's recommended. We've said that a few times. Men ACWY single doses. We know at the age of 1. But if you've got other risk conditions, I think last time we talked to you about the poor kid that had the car accident and lost their spleen and therefore needed extra meningococcal. Just check that history, because remember that Men B is part of the, also part of the South Australian program. So if you've got people that are, that's why checking the air is important, which you all do anyway. lots of resources for meningococcal out there as well. Okay, scenario 4. How are we going? Are everyone awake still? Yeah, okay. Molly is 70, and lucky Molly's off to 6 weeks in Eastern Europe. What does Molly need? Passport. Passport, lots of money, yeah. So Molly has had Prevnar 13 and flu, but they were last year. And she had COVID in October of 2022. She's only going to city, so she's not going sort of, not stopping off in Southeast Asia and trekking to a dengue, Japanese encephalitis prone area. Molly has not had positive COVID diagnosis for 12 months. So she's about to head off. She's going to get the flu shot right now. Excellent. She's going to get Zostavax, although she might, depending on how quickly Shingrix can get on to be funded, she might be able to get that one as part of the free program. She could get a COVID booster because she's 70 and she hasn't had an infection or vaccine for 12 months. Of COVID. Oh, so in terms of right now, so the question was, is if Molly's already had, she possibly could have had 5, possibly, if she was an early adopter. In a sense, we're disregarding the previous doses. In real life, yep. We don't really care what you've had in the past. If it's been more than 6 months and you're in that age group, over 65, get a booster. Even if you only had 1 dose, we just sort of disregard the previous. Does that make it a bit easier or hard? I don't know. She can get a Boostrix, although that's not funded. And then, like someone else pointed out, STI screening for the young couple. She needs other travel advice. What else? Okay, number 5. So Bernie's a 53-year-old man who identifies as Aboriginal. He is researching native birds in the marshlands in Western New South Wales. And he likes fishing, but not necessarily pig shooting. He's up to date with COVID-19 and seasonal flu, but he does not have any history on the air for other vaccines. What are the recommendations for Bernie? So he's had flu, he's had COVID, he's had Boostrix. He needs JEV because he's, in the JEV prone area. He's Aboriginal man, so he does need Prevnar 13, and you can see there's that pneumococcal algorithm down the back there. Prevnar 13 now, a Pneumovax 23 12 months later, and then another one 2 to 5 years, and then Shingrix as well because he's Aboriginal, he's over 50. Yeah, he's had a Boostrix in 2020, but I'll come to the tetanus thing because there's a whole range of things. I'll come to that in a second. Does that sound all right? MMR is a good question. Yeah, if he's not had that, you could give him an MMR. Yeah. There's that pneumococcal one I was talking about where there's a handout down the back there. This is this HALO idea, the health, age, lifestyle, occupation. Okay, so there are some additional recommendations. So we talked about the second dose of varicella is recommended, but because it's not on the schedule, I doubt many people get a second dose, to be honest. Men ACWY, men B, that's influenza for anyone over the age of 6 months is recommended. Shingrix is recommended from 50, but won't be funded until it's the 70s. Tetanus, which I'll talk about in a minute. So tetanus booster doses. So because we had that recent death in northern New South Wales of a person with tetanus, we wrote a conversation article just reminding people about the need for tetanus booster doses. And what this sort of says is that about 1 in 5 of us, middle-aged people, some of you, have low or antibodies to tetanus. That's 1 in 5 of us. A single booster dose will bump up your protective levels, and so that's why I might go out after this and get a tetanus booster because I haven't had one for 10 years. So that's just a reminder, because what we do know is that certainly over the age of 80, and all of the deaths we've had in tetanus in Australia in the last decade, everyone has died has been over the age of 80. Okay? So just a reminder. And the other thing is for travellers as well, because you can imagine you're in Bali and you fall off a motorbike and you can't remember what your tetanus history was. You get a big cut and gash in your leg, it's dirty, there's lots of stuff in it. Getting access to tetanus immunoglobulin and a tetanus vaccine could be hard to do and expensive. Recommended, not funded. Yep. Open up the wallet. But it's worth reminding folk, and I often think about that tetanus, particularly with travellers. And as I said, certainly over 80, they're the unfortunate handful of deaths we've had from tetanus. Lots and lots of information which we won't go through now. Okay, so Halo we talked about. This because of the time and because I don't want you all to fall asleep. What we tried to do in these next few slides, which I'll leave with you and you can look over, is just sort of summarise the sections from the handbook for people, so that you can look down this and think, immunocompromised, I'll think about extra doses. So the things to think about in the halo are the immunocompromised, Aboriginal and Torres Strait Islander preterm infants. They might need extra doses depending either their gestation or their birth weight. Okay. Pregnancy, we've talked about a fair bit. Migrants, refugees, asylum seekers. Travel, we talked about tetanus, yellow fever, remember? So you know all of this. But and then that's the lifestyle part. And then O is the occupational risk. That brings in vaccines like Q fever, Japanese encephalitis, etc. Lots of infographics. Anaesthesia, surgery. There's no problem. Sometimes at kids' hospital we do, particularly for the kids that are a bit hard to vaccinate, if they're having a procedure, having some sedation, anaesthetic, we often get a vaccine in at the same time. Adverse events I'll talk to in a minute. Groups of prisoners, men who have sex with men often need extra doses, and immunoglobulin. So I'm not going to go through it because it's a bit boring and you all fall asleep, but you can have a look at it later on. Okay, so an older person who has non-adjuvanted flu vaccine does the vaccine. So they've turned up, they're over 65, they've had just the standard flu vaccine. What would you do? Would you go back and say, look, terribly sorry, we accidentally gave you VaxiGrip. You really should have had Fluad Quad. Or just say, you got some flu vaccine, away you go. Either is right, basically. You can do either. You probably just need to tell them that you got the you got the standard one, over 65s are recommended high dose or Fluad Quad. If they were immunosuppressed, or you might say, look, in actual case, I'm not quite sure that low dose one works so well for you, I will give you the adjuvanted one. but it's probably not a major game changer. A vaccine administered was expired a week ago. Does it need repeating? This is where you get to talk to the PHU who's going to answer it for you. So sometimes it depends. So sometimes when we get approached by these things, we can actually discuss with the manufacturer to say that expiry date has a margin on it. Not saying ignore expiry dates, but you can. There's sometimes a margin. So if you discover that's happened, talk to the public health unit, and then we can help. They can often talk to immunisation section and get an answer. Is an additional dose of Bexero recommended at 2 years? So this is slightly different to what's in the product information. The immunisation handbook at the moment does not recommend an extra booster. So it's sort of 2+1 schedule or 3+1 schedule. So the 2, 4 and 12 months, or depending on their immune suppression state. Preferred zoster vaccine. So at the moment, Zostavax is the one, but remember we cannot give that to live attenuated. Shingrix is now on the PBAC, which we've talked about, so that probably might become the recommended one, although it is 2 doses compared to 1 dose. Okay, so I'll stop there before we, in the last sort of 20 minutes, that's gone pretty quickly. See if you've got any questions. So I covered the new stuff that's coming and a few scenarios for you.
Oh, hi there. Just want to ask about the Hep B vaccine. My colleagues and I came across an issue. We were previously giving the Endrix vaccine, and then the new supply came in as the other brand, the Hep B2. We've got a lot of patients that started the Endrix for their course, and it's not recommended to interchange. So what's the best practice recommendations?
So you can't get access to the other to complete the brand. Yeah. I think if there's no access available, then I would just finish the course with the other brand, to be honest.
Got a question here from Slido, Nick.
Oh, yeah.
How long does immunity last for men B and men ACWY when given at a young age? And that's to answer a parent inquiry.
Yeah, it's a good question. So it's being watched, and because the UK started their program, must be nearly a decade ago now, with an infant program. So they're not yet recommending booster doses in adolescents. Some of those kids will be getting towards adolescence, so they'll be looking for breakthrough infections. At the moment, however, we don't have evidence to say that men ACWY at 1 requires a booster dose down the track. That's why the product information for Bexero does talk about a booster dose of antibodies, but that's different to what's in to boost your antibodies. That's different to what's in the handbook. So at the moment, no recommendation for a booster, but it is being watched. They're quite good vaccines for these conjugate vaccines. So we can get away at the moment with a single dose, but looking for breakthrough infections. It might well be that we say, the kid born in, a couple of years ago, they got men ACW at 1, they might get a high school booster dose if we see evidence of breakthrough infections. Any other? So we might move on to adverse events. So this is the definition of what an adverse event is. It's an untoward medical occurrence which follows immunisation but does not necessarily have a causal relationship. Okay? So this is the tricky part. Just because it's reported, it's followed, people often assume, therefore, the vaccine caused it. Okay. Now, it would be very hard to argue that the vaccine didn't cause that, except if that was the arm where the vaccine was not given and that was a bee sting. So you could, that's the sort of, people might come and say, look, this is my kid's arm, but actually we gave it in that arm. So there's also this one, rashes. That's a measles-like rash, which you can often see a week after the MMR. But there are many other viruses that can cause that sort of rash. Adenovirus, roseola, very common. So just because it happened after the vaccine, the hard part is to assume that it actually caused. So fever happens after the vaccine, but it doesn't necessarily mean that it was caused by the vaccine. Okay, so WHO classifies adverse events as in this sort of way, and it could be a product-related one. So that was that febrile seizure story from 2010. An error in manufacturing, an error in immunisation administration, immunisation anxiety-related, which I'll show you in a minute, and then coincidental. So people report, I fell off my bike after the vaccine. Well, it is an adverse event following immunisation, but could you have had a faint? Could you just got on your bike after your vaccine and fainted and fallen off? But this is the sort of things that we have to deal with. And over the COVID vaccine rollout, with millions of doses of vaccines going to the Australian community, the reporting of adverse events to the State Health Department went like that. With thousands of reports coming in, and we had to sift through them all and work out which one of these categories they were in. So what we like to do is detect them. They get notified by you guys, often get investigated and analysed. Sometimes we do causality assessment. And then, this is the sort of idea that led people reporting myocarditis, notified, investigation, analysed. Yeah, it could be signal there. Therefore, the feedback was myocarditis has been reported and gets notified to you guys. In Australia, we have these sorts of systems for adverse event surveillance. So I'll show you. So what happens most of the time is the person gets a vaccine and they have no problems, no adverse event. That's the majority of people. Or they might get what we call an expected side effect, a bit of a red sore arm, a bit of a fever. If they do get an adverse event, most of the time it's either self-managed or they do actually turn up to GP, pharmacy or hospital. Okay. The adverse event can be reported to public health authorities, and that's a passive report. And it's often you guys reporting them, although the member of the public can also report them. And that's the passive system. Okay. If that person does present, they often may be referred to NSWIS, which I'll talk about at the end, where we can advise on any management of that adverse event, and probably what's the harder part is the revaccination. So that's the passive system. We also have an active system, which is this one, which the slide's missing. But in the active system, although is it this one? No, sorry, I'm just getting a bit lost. Oh. In the active system, what we do is we will actively survey the person that got vaccinated, and that's what Ausvac Safety does. So you get your vaccine by your GP or the hub or hospital. We send that person a survey 3 days later, electronically via email. You fill out. Many of you may have already filled out this survey. We collect all that data, and I'll show you some of that. In New South Wales, it's pretty complicated. So vaccine goes to the person. They might get an adverse event. They may seek healthcare. The healthcare provider reports that to the public health unit. The public health unit then will either advise on revaccination, collect the clinical information and put it onto NSIMS, which is the statewide database. That data then goes through to the TGA. So the TGA is getting reports from all of the states coming into their TGA database. New South Wales Ministry of Health will scan the reports coming in, which they do. They identify serious adverse events, and then what we had set up during COVID was experts to review TTS cases, that clotting story, the Guillain-Barré syndrome. So we had a bunch of specialists that were reviewing the serious adverse events, which are called adverse events of special interest. I'm not quite sure the rings are there, but anyway. So you're already doing this, but the message is report them through to your PHU, because we actually don't have as high a reporting rate as Victoria. And I always like to keep up with the Victorians. So we've got to, not that, I'll show you at the end the reporting. So this is what active surveillance is really, which I talked about. We actively survey the person, or the other thing that we do is we actually monitor hospitals. So we have nurses working in a group called PEDS who will actively scan the paediatric hospitals in Australia. There's 8 of them, or 8 tertiary ones, looking for adverse events. And we collect that data. And we also have, New South Wales has a really nice system called FREDS, which is the Emergency Department Surveillance System. So they're scanning the emergency department presentations and collecting adverse events that way. So this is AusVac Safety. This is this little text-based you get on your phone. First thing is, did you have a reaction? If you tick no, that's the end of the survey. If you tick yes, you get more questions. That all comes back to us, and pretty sure where's the next slide? This is the sort of data, and you might think, well, how do you use that? Well, as I said before, you can show people in your surgery this data if they're particularly interested in it. PEDS is that nurses scanning the presentations. They're looking for things like interception. They're looking for things like encephalitis, acute flaccid paralysis for polio, etc. So that's what that PEDS is. So I just wanted to talk to you a little bit about some of the adverse events of special interest, and we'll go through those. So when we think of these adverse events, they're the sort of things that could happen with natural infection. So, for example, COVID, natural real-life COVID disease can cause myocarditis. So theoretically, could the vaccine also cause myocarditis? Okay. We know that anaphylaxis can happen with vaccines, or there's a theoretical association, and that's, for example, you can imagine that you're giving a nasal flu vaccine with some flu up your nose, that it might actually stimulate some inflammation around this area and cause a Bell's palsy. So what they do is they divide this into natural infections, theoretical associations, and they've listed all these adverse events of special interest. And so when you guys report them through to the system, we and other states look at these serious adverse events, and what we try and do is understand who's getting them, what is the causality, or is there something else in the person that caused this particular event? What are the longer term outcomes? Do they happen again if they get another vaccine? So this is this type of data that we can look at once we get the report. Okay, so this is an example of an injection site reaction, which you all know. Happens in the first sort of 48 to 72 hours. Usually the kids are not too sick with it. Most of the time they can still go about normal business, and it's usually gone by a week. This is some work that one of our nurses, Kath Tapper, did, looking at anaphylaxis after COVID vaccines. So during the COVID rollout, as you know, that there were people were being vaccinated in environments like this, and you might be sitting in a row in chairs, and then all of a sudden people were collapsing. So we got lots and lots of reports of what was thought to be anaphylaxis coming through the system. In actual fact, we had over 200 anaphylaxis reports that came in this period. What we then did is looked at all of the detail about them. There's a thing called the Brighton collaboration, and that defines levels of certainty. Level 1 Brighton is it really was anaphylaxis. Level 4 and 5 are not quite sure. And as you can see, about 50 or just over 55% of them were level 4 or 5. And only 40% were level 1 or 2. So even though these people level 4 or 5 probably weren't anaphylaxis, they got given adrenaline because someone thought, oh, you're fainting. but most of them probably weren't anaphylaxis. So what we wanted to understand is what happens if we revaccinated them. And we went about doing this, and when we looked at the data, nearly 80% of them had a further vaccine, and very, very few of them had any adverse event. Only 14 out of 170 had another recurrence. So it probably wasn't anaphylaxis to begin with. It probably was, I won't go through that detail, but it was probably this, an immunisation-related stress response, okay? And this has not been known about for many, many years. It sort of first came to prominence with the HPV vaccine, where there were girls getting it in a school-based setting, and you can see that sort of spike going up in that 2013. That's where kids were fainting. So the immunisation-triggered stress response is a known phenomenon, and that's probably what was happening. So COVID, TTS, this is not so much an issue anymore because AstraZeneca is no longer really being used. So the people that are on this, we are following up a lot of these people that have had this to look at their longer term outcomes. Myocarditis, there's some guidance there. I think this will be updated shortly, but the guidance there about how to manage those people that have had what might be myocarditis or pericarditis after the primary course. Like I mentioned, not as likely to happen with the booster doses. We are following up myocarditis and the TTS cases across the country. So there are nurses working in different states who are actually phoning these people to see how did you go at 6 months and how are you going now at 12 months. And in New South Wales, our nurses are doing exactly that. Some of the data that's emerging from the Americans is saying that on follow-up, most of the people have recovered, so which is good. They're not having any issues with abnormal, cardiac ECGs or echoes, although a few of them are still having cardiac MRI abnormalities, okay? And this is just an example of that sort of scar. The little arrow is pointing to an area of inflammation in the heart muscle. We don't quite understand why this has happened in some people, but which is why if you have that as part of your pre-vaccination checklist, how did you go? If they say myo or pericarditis, then you need to think about, getting some advice. I won't go through this one, it's just too much detail, but because Zostavax. We are also doing studies with genomics. So what we're doing is collecting biological samples from people that have had reactions, such as TTS or myocarditis, and we're sending them to look at their genetic screen to see if we can identify any genetic markers to understand why they might have had such a reaction. The schedule has changed a little bit now, so in terms of reporting or investigating to New South Wales Health, it's up to your local public health unit director to decide whether or not that adverse event is of severe interest enough to be flagged, and then we convene a working group for it. So this particular, these are the sorts of things why we're important to keep on top of adverse event reporting, because this was sort of reports in the UK a few years ago, but in actual fact, this poor girl actually had an underlying oncology problem, cancer problem, so it was nothing to do with the vaccine. So, this just to take home the idea that just because it's an adverse event after the vaccine doesn't mean it was caused by the vaccine. Yep. Benefit versus risk. We won't go into that much detail. So to summarise for you, your role as providers is to make sure that if you, in your pre-vaccination routine, or if you become aware of other adverse events, to report them through to the PHU. Hopefully you've got an idea to understand how PHU then puts them onto NSIMs They then get looked at the State Health Department, and if they're a severe adverse event, they'll often call us and we'll pull in together a working party of haematologists or immunologists or neurologists to discuss it in more detail. This is important for us because, like I said earlier, new vaccines are coming. So RSV, there's new pneumococcal vaccines, there'll be combination vaccines, flu-COVID combination vaccines. So the reporting is an important part of the whole process. We do have the Immunisation Specialist Service, and there's the email down there. We can help you with questions about, is it safe to vaccinate this person? Does this person need extra doses? Or if there are particular people that are difficult to immunise because of a range of reasons, we do have capacity to try and see these kids at the moment and younger adolescents to sort of give them what we call a safe pathway vaccination. Other hospitals are also, I think Nepean is trying to set up one where you can vaccinate these kids with additional, child life therapists, sometimes some sedation, and we can, use those pathways. So that was it from me. We've got time for a few questions before you get day in the life of the immuniser.
We've got one here, Nick.
Yep.
Is shoulder pain after vaccination an adverse event?
Is shoulder pain an adverse event? So if it wasn't there before the vaccine and happened after, and it's more than just a sort of local injection, it could be that server. So that's that shoulder-induced vaccine-related adverse event. I think it's server. And that's often because it's given too high and it's actually hit the bursa. And the bursa doesn't like having a bit of aluminium and a bit of antigen in it. So the people will get a sore arm. So it could be that. So I think if in doubt, report it, because if you report it and then all of a sudden 10 other people report it, people might say, hang on, there's 11 reports of shoulder injury. Is there something to do with the batch? So your report is useful.
Perfect, thank you.
Any other? We've got a bit of time for...
There are lots of questions here not relating to adverse events. Do we want to hold them off to the Q&A section at the end? Yeah? Yeah.
I don't mind, whatever you... I've got my... Any other whole of life type questions? I think what I tried to do with that was to bring up some of the little common scenarios that you might come across. Nope. I put you all to sleep, have I? Well, it's all very clear, hopefully. Okay.
Thanks, Nick. It's a pity we don't have an IV station for a direct injection of caffeine. I'm up for that, if anyone... Happy to offer up my arm. So just some quick reminders here before we move into Kim's presentation. So just a reminder here that the NIP Shingles vaccination program for 71 to 79-year-olds ceases on the 31st of October. If anyone is keen to work on a clinical audit to identify eligible patients to receive a free shingles vaccine, please contact Michelle Drewers at the PHN. It is important that all eligible people are vaccinated before this funded program ends. Michelle is also available to discuss other immunisation QI activities that are of interest to you all. As always, thank you, Michelle. So please welcome Kim Rice, Clinical Nurse Consultant, Immunisation Public Health Unit, Western New South Wales LHD, to share her experience of a day in the life of a nurse immuniser. Kim will then be joined by Belinda for an interactive chat around common immunisation questions and scenarios. So Kim, welcome.
Hello everyone. I'm normally at the Dubbo Immunisation Conference, but it's been really nice being here today, and I actually saw someone that I did my child and family health training with in 2002, Laura, so it was lovely to catch up with you. I'm Kim, and I'm new to the public health unit. I've been here acting in this role for about 6 months, I think. So my normal job is in child and family health, and for the people that do know me here, that is a very big passion of mine. And immunisation has sort of really goes inside with that passion. I love my vaccine fridges, I love vaccines, so it's sort of been a very good transition into the public health unit. So I have lived, I was born in Nyngan, I was raised in Cobar, I was educated in Sydney. My dad used to say I was educated at the Cross. And then, but ever since then, I've actually done all my nursing in either rural New South Wales and just recently for a couple of decades in Dubbo. So I became a nurse immuniser at the College of Knowledge back in 2005. So back then, did everyone remember doing that? It was an assignment and you sent it off. And these days they just do like multiple choicey things. It looks like pretty good. So I wish it was like that for us. So I'd sort of been a nurse immunisation for years, but you just sort of did it. You didn't sort of think you were anything special. But I was working in the COVID vaccine hubs, and we got these lovely expert nurses from Sydney. They came to Dubbo to help us, and they were really lovely, but they kept on telling me, oh, we're Annies. Did anyone ever heard that? Like, they kept on telling us all the time, every shift, well, we're the Annies, you know, and they sort of ran the show and we were just these people that helped. You know, one day I got the best of me and I said, well, what is an Annie? And because I thought it must have been something special that you got in Sydney, and they said, oh, we're authorised nurse immunisers. And I went, well, so are all we. We've been them for decades, because they'd only just recently got there. So I found that quite interesting that they thought they were very special as Annies. So the day in the life of a nurse immuniser, well, I'm sort of just going to put a bit of a, look, I really want you to stay awake. So this is very light and not quite as formal as the other presenters, but I think a lot of you will be able to relate to this. My children have endured the trauma of having a parent as a nurse immuniser. So you get onto your children's vaccine statements and you sort of have to research it. You know, you scroll. They seem to have pages of vaccines compared to people whose parents aren't nurse immunisers. And then, you know, the minute your children says, oh, we're going to go overseas, you go, oh, well, you know, and then all of a sudden their vaccine statement becomes another page because they have to get all these vaccines done. My middle child, when he left school, he did a gap year, and this is back in 2017, and he said, they were in the staff room and his boss said, okay, hands up, who would like a flu vaccine? And my very good son, he was the first one to put his hand up. Yes, and he was only 18 years. Yes, I want a flu vaccine. And the boss sort of looked at him and thought, well, that's a bit weird, you know, and he sort of just questioned his enthusiasm. Why do you want this flu vaccine for so excitedly, Jeremy? And he said, if I knocked back a free flu vaccine, my mum would kill me. And so I think a lot of you can probably relate to that. When you tell people you're a nurse immuniser, like, you know, I'm assuming you all get this vibe, they just say, oh, all you do is just put needles in people's arms all day. And if only that was true, because we know that that is only such a small part of being a nurse immuniser. If only it was that easy. And I better flick through. I'll forget to go through slides. Okay, so that's me in the COVID vaccine. As you can see, I'm a real introvert. I wear very boring clothes, and that was before the mask wearing, so that must have been really early on in those stressful days. And can everyone remember that clip? We did that's my child and family health team in Dubbo. We did a clip, but that's a couple of years ago now. Okay, so I want to talk about the joys of being a nurse immuniser. So PROTA. Does everyone love PROTA? I actually Googled it. I didn't even know what it stood for. It stands for Provider of Digital Access, but I reckon it's sort of a bit of a provider of digital angst a lot of the time. Has anyone ever forgot their phone? You know, when you've got to log on and you need your phone for the code and you've left your phone at home and it's never a good day. And then the lovely 9 steps you've got to go through to get to the screen you want, and then it logs out, and then it has some funny code things, and you spend your whole day going in, out, in, out. And, you know, often you need it because your client comes and they don't have a blue book, and then if you can't get into Proda, that's really going back in the old days when you just have to guess. Does everyone know... If you need to get Proda access, you have to contact the public health unit. And that's something we do regularly, don't we, Belinda? Like, people are always sending us an email, we need Proda access. And to get Proda access, you need your immunisation certificate, you need to do that cold chain heady thing online, which I think Belinda mentioned earlier, that it's good to do that every 12 months, because sometimes people send you a certificate that they did like 6 years ago. Well, it's actually good to have an update. And then there's a form, a Proda form. I know I'm talking to people that just work for Western New South Wales. I'm very sorry, I haven't sort of worked in that GP space, but I have talked to lots of people that work in that space and I'm learning. And then every 12 months you have to renew your access. And some people think they have to go through us, but actually they only, if everything's just the same and your work hasn't changed, you can just email the Proda team directly. But if there's any changes to your employment or any queries, just please contact us. I better go through the next slide. CHOC. Who does CHOC? Hands up. Who's... Oh, there's quite a few of you. That's fun, isn't it? So CHOC's for people that work for Western New South Wales Local Health District. For us to put immunisations in, we have to, it's like this Excel spreadsheet and you've got to put each individual thing in, and it's very, very tedious. And there's no drop-down boxes. Like, I think for people that work for GPs, there's drop-down boxes when you're adding, well, we don't have that. We have no joy. We just have to individually, and like the other day I gave a 12-month of 5 vaccines, and like, it's just so tedious putting it all in. But watch this space, because they're doing a big project at the moment that we're going to be like the GPs. We're going to put it in CHOC, and by some miracle, it's going to go straight to air. So that's going to be fun. So I think the big reminder is, because that's going to happen, to, you know, just really make sure that all your details on CHOC and on the immunisation charter spot on, because otherwise, you know, there might be some hiccups with that then going straight across. I've got a lot of things in here that Nick talked about, so actually, but I'll just do a little refresher. So, because these are questions that we get a lot in the public health unit. So the National Immunisation Program, and I'm just mentioning vaccines that are not on the program but are recommended. So the Nimrix and Bexzero from all people from 6 weeks of age. I had a nurse ring me the other day and she was worried because her client was going to the GP and the baby was going to have Nimrix at 6 weeks. And, you know, that is fine. It's just, it's only free at 12 months. So you'll need a script for Nimrix if it's given before 12 months. And for Bexzero, you need a script for non-Aboriginal children in New South Wales. And as Nick said, you need two varicella-containing vaccines are recommended, but are only funded at 18 months. Where to jab and how to jab. So as I said, I'm trying to keep this light. So, you know, if you were to give 4 vaccines on a single visit to a 12-month or older child, would you administer them all in the same legs, administer 2 vaccines in each deltoid muscles 2.5 centimetres apart, cry and go home with a headache? I'm tempted to do that often. And administer 1 vaccine in each deltoid and thigh. Because sometimes those I'm talking about that because sometimes, you know, everyone's different and you might get a very tiny 12-monther coming to the clinic, particularly if they're premature. And, you know, you're staring at that deltoid muscle and it's about that big. Yeah, so sometimes, like, don't be afraid if you really feel that's so tiny that, you know, use the legs. You know, don't feel you've got to put them all in the thighs. And sometimes it's good to have a good system in place, like as Nick said before. So, you know, 12 months, you've got all these, yesterday I had 5, all these vaccines all lined up, and you're thinking, where am I going to put everything? But it's good to always think, give Bexero and Prevnar in arms and separate arms, and then sort of just work out what to do with all the others. But they do say that MMR and meningococcal ACWY, they're less, like they're good ones to give in the thighs if you want to give something in the thigh. I hate that ad. There's an ad on social media at the moment, and it's this lovely couple with their lovely, she looks about 4 in the waiting room, and then the GP calls them in and it's all happy days, and then they give she puts the Band-Aid on the thigh of the 4-year-old. Like, has anyone seen that recent ad? You'll all see it now after today, and I look at that all the time. I'm going, why are they giving that vaccine in the leg? Because we really recommend from 12 months older to use the arms. Okay, so what is the answer to these questions that I've put up here? What was that, sorry? Yeah, B and D, that's right. So if the deltoid mass is large enough, and as I said, some of those little prems, they're very tiny, you know, you can give up to 2 in each deltoid muscle, separated by 2.5, or try your best to get 2.5. Sometimes that's really tricky with a moving child. And then I just talked about that shoulder injury related to vaccine administration. It's rare, but often it's when it's given too high in the shoulder joint. So I've just got the picture, so you roughly want to give it. It's got the little outline on the deltoid where to give it, and in the thigh too. Okay, catch up. That's fun when you're a nurse immuniser, and often it's 3 o'clock on a Friday afternoon. Your admin person gives you a card that looks like that, and the family want you to perform a miracle and put it on air and be all up to date. Every catch-up's different. So I think when you receive a catch-up, always renew the history, look on air, look on anything that the parents can provide. So immunisations that are given overseas, slips from school vaccinations, yellow vaccination cards, GP records and overseas records. The key with catch-ups is to always check the patient received doses at the correct age and dosing intervals. A lot of these overseas ones you'll see at 9 months that measles will be given, or even in some countries they have like a measles rubella vaccine, but it's not MMR. And in Australia we want 2 doses of MMR, and the first dose to be given at 12 months and then another dose at least a month later. So I see a lot of people, they get a card like this and they see measles at 9 months or something, or even a measles vaccine at any age, and they record that as MMR, or a measles vaccine is not MMR. So we're talking like we want 2 doses of MMR. I like to, because sometimes you actually don't know what vaccine they've been given when you're recording it on air. So if I don't know what the vaccine is, I only can see the disease, I'll just record it as a generic pneumococcal vaccine or a generic diphtheria, tetanus, whooping cough vaccine. Yeah, don't make it up. Like if you don't know, if there's nothing there that tells you what the vaccine is, just record it as a generic. Sometimes with Proda again, our provider of digital angst, it's very difficult to record vaccines given overseas if they don't have a Medicare card. I talked to some lovely nurse here today from Cowra, and she was feeling not that love, and I was telling her I don't feel that love either. And sometimes when they don't have a Medicare card, I don't know, Proda just plays up. You record some things and then you can't see what you've recorded and it gets all messy, or it logs out, or, you know, and you're just there tearing your hair out. So there's actually this form called the Australian Immunisation Register. It's an immunisation history form, and I can send it out to the PHN and they can send it around to people. And you can actually write all the vaccines that have been given overseas on this piece of paper, and then you can actually upload that to air. And sometimes it's good because then you've got a record of what you've actually worked out, and then I upload that plus those the vaccines given overseas and just upload it all to air. And it takes them a couple of weeks, but they will put it on air for you. So I find that very helpful. Has other people done that and find that helpful? Anyone? Yeah. Yeah. Yeah, I find that so helpful, and I hope that will help other people in the room too, because sometimes it's very difficult. It just plays up and it won't work. And you're trying to enter all these vaccines, and I just love that form so much. And sometimes in overseas countries, another vaccine to look out for is Hep B. They'll do this quite unusual schedule, and they'll be given a Hep B at 6 weeks, 10 weeks and 14 weeks. And then sometimes you enter that in air, and air will say, oh, we actually want another Hep B. And I can see why, because that's sort of an accelerated Hep B schedule. Because you know how in Australia we like to have, 4 months between dose 1 and dose 3, and at least 2 months between dose 2 and dose 3, that sort of language. So I think with that accelerated schedule that they do in some countries, air don't like it, and they'd actually like you to give you another Hep B. So, sometimes you might see that and you go, why do they want to have another Hep B? They've already had 3, but they just don't like the intervals that it was given. But you can always ring us at the Public Health Unit and we can talk through that with you. I hope I'm making sense. And then there's this good free translation service for Australian citizens and new migrants settling permanently in Australia. And that's that website there. And it's free, and you can just, because sometimes they come with the immunisation card and you can't read a thing on it. It's in Arabic or it's in some other language, and you go, thanks, but I have no clue what that is. And I get them to send it to that translating service. So as I say, every catch-up's different. Belinda and I had a look at this. There's great resources out there. So, like, the immunisation handbook is so valuable. You can just look up every disease. And when air works, it's quite valuable too. Like, they can, if that's all working well, they can give you an idea of what's due as well. So that's just that's a resource. That's in the handbook, isn't it, Belinda? Yeah. Cold chain management. So this is just a little silly questionnaire as well. In the event of a cold chain breach, do you, A, call the Public Health Unit any time of the day or night? We go on an on-call roster. You can ring us at 3 o'clock in the morning. We won't care. Not. We love receiving calls. B, discard the vaccines and call the Public Health Unit. C, acknowledge there's been a cold chain breach, but do not worry about calling the Public Health Unit. They have enough to do. D, isolate the vaccines, label do not use, then contact and isolate the vaccines in the fridge. Don't take them out of the fridge and isolate them. Label do not use, then contact Public Health Unit in working hours or the next business day. So what do you think would be the best thing to do? Who said A? Please say D. Did anyone say D? Yes, thanks. Oh, can I go back? See at that top corner, can you see that it's purple? Yeah, I got that. That's my photo. So one day I unpacked, you unpack the vaccines and you get pretty complacent. Well, I was really complacent that day because I wanted to go out for lunch, and I was like going through it going, and I nearly died. I picked up that thing and I went, oh my gosh, it's it's meant to be clear, and I was like, bright purple. So that's what's happened if the vaccines get too cold on transport. It does happen. Has anyone had the purple thing? Yeah. It's not, see, it's all us oldies that have got the purple thing. Yeah. And then someone received a box that had holes in it too. So sometimes the transporting's not so good. Yes, and the correct answer is D. Please don't call us in the middle of the night. Like, we feel sad for you that you've had that cold chain breach, but just contact us next business day. So when you do get a cold chain breach, there's 4 sections of this form that you need to fill out and email to the Public Health Unit. And please attach items that are requested on page 4. Most of you are very good at this. Yeah. And if you're having any troubles, just call us. I mean, call us, but trouble filling out the form, I mean. Okay, I've got another question. That's actually my son. So a day in the life of a nurse immuniser. I remember I had a really busy clinic. Like I was going to have this really busy day, and everyone was getting ready to go to work and to go to school, and my little 6-year-old just came up to me and he looked at me and he looked like that. And I went, gee. Anyway, so he was talking okay. His lips were a bit swollen, but his tongue wasn't swollen, and he was talking okay. And so I sort of went, oh dear. And so I thought to myself, oh, he's had a reaction to something. So I'm a very calm person. I sort of thought in my head, well, 7 o'clock, I'll wait till 8 o'clock and I'll ring the GP and I'll get an appointment by 9 o'clock, I reckon. Anyway, then my husband comes out. He's not medical at all. And he looks at him and he goes, oh my God. And he starts having like this absolute panic attack, going, oh, we need to take him to the emergency department. Oh my God, look at him. And I sort of said, well, and Dubbo was really short-staffed, and I sort of said to him, well, if you want to take him to the emergency department, go ahead, but I'm not. So he then thought I was terrible, terrible mother, and he went off to work and kept on texting me every 10 minutes, is he okay, is he okay? I said, yeah, he's okay. And I remember I did ring up at 8 o'clock, got an appointment at 9 o'clock, got into the GP. I know the GP well, and they sat there and they said, why didn't you take him to the emergency department? And I said, because, his Glasgow coma score was above 8. And I thought, he's okay. I said, if it was below 8 and they had ventilated patients at school, I probably would have sent him to school. Like, he's okay. Anyway, so they prescribed them some medication, and I remember going to the chemist with Samuel after that. And that was that was probably in 2010 this happened. And back in those days, you could walk the streets wounded, sick, coughing, no one cared. So off we went, took him to the chemist, and I probably had some big flowing skirt on, and I remember I handed the script in and they looked at the script and said, that's a very big dose for a 6-year-old. And little Samuel was hiding behind my skirt, and then he sort of pulled out from behind the skirt and they looked at his face that looked like that, and they went, oh, okay, he can have that dose. I went, thank you. So I think the story behind that, because that took days to go down, days and days. So I was getting everyone's information, why did that happen? Was it gluten? Was it egg? Was it milk? Was it, everyone was trying to diagnose how he could get an allergic reaction to something like that. And I remember I was stirring people and saying, he's had a vaccine, that's why. And they were like, and I went, I'm only joking, like he hasn't had anything. And it's funny because we never found the cause, and he's never had another episode. And he's now 20 and he's got no known allergies. So what I was trying to sort of get to the point is, like, sometimes things just happen and we don't know. And if he'd had a vaccine that day or the day before or something, we all would have jumped and went, oh, it was the vaccine. So this is a question. After giving a 4-year-old the 4-year-old vaccine, you receive a phone call from a mother the next day concerned as her child developed quite a large localised reaction to the injection site. What would you do? A, I'm very dramatic. Run outside screaming, call 911. B, report it immediately to the public health unit. C, reassure mother that this is a common reaction 24 to 72 hours after vaccination and should resolve spontaneously within 3 to 5 days. Or D, advise mother to contact a current affair. C. So that's actually quite normal, and as Nick said before, like, it's quite normal to get, and they even have it on the hand, like, the side effects after the 4-year vaccine. It's quite normal. You just would worry if it extended below the elbow or above the shoulder. But I know I get a lot of phone calls about the 4-year needle. Do other people too? That they can become, what do they say, 1% have that quite large reaction, yeah. And a lot of the time the parents just know. I tell the parents now, I just say, look, this is, your child's 4, they could get a really large reaction. So then they know. and it's, you know, at the end of the day, we're all repeating ourselves. So what's an adverse event? They are notifiable under the New South Wales Public Health Act. So to report it, you have to download this TGA thing, and then I'm just talking about that immunisation providers can contact the New South Wales Immunisation Specialist Service telephone advice line for clinical advice and support on immunisation for parents with complex or unusual medical backgrounds or have had an adverse event following immunisation. Because, like, I can appreciate if someone's come to you and they've had a reaction to something, you know, you're not going to be really keen to give another one unless you talk to someone about it. So there's somewhere, a place you can talk to. And I think that's all from me. It's nice to meet you all. At least you know I am in the public health unit and I'm there Monday, Tuesday, Wednesday. And yeah, no question's a silly question, and I hope you feel that I'm someone that you can call now, and yeah, I'm happy to talk through it. Sometimes it's just good to talk to someone about something. So I'll be looking forward to all your phone calls. And I think Belinda's going to come up now. Ah, sorry. Oh, okay.
That's right. Yeah, don't go too far, Kim. Thank you. AKA Annie, was it? Annie, sorry. How Australian is that, eh? Okay. So yes, Belinda is staying on to facilitate this afternoon's Q&A panel. But our panel members will include Nick, Wendy, Alice and Kim for this session. So please submit those questions via Slido or raise your hand and wait for one of those roaming microphones from the team aside. So Belinda, if I could ask you, probably best to come to the rostrum here and you can, or sit aside and...
Hello again. I'm just going to buzz through a couple of slides here just to see what pops up. Okay, so the vaccination for healthy ageing. We've got a little brochure, a laminated copy of that down there. It sort of follows on from Nick's presentation. So again, another handy resource that you can use for your senior clients, just to assist you in reminding what to give your older people. The pneumococcal that we've talked about. So yeah, so they're all just great resources that are available. The interchangeability of vaccines. We get lots of questions about that at the PHU, and all of this information is straight out of the handbook. So if you're ever unsure about interchangeability, it's always a fantastic resource. And I think on Slido, there was some questions about that, so we will get around to addressing those.
I think we answered that about the Hep B one, didn't we? Like, yeah, if only one brand's available, yeah, you just use the different brand. Is that right, Nick? Yeah.
I think Nick showed this earlier, so yeah, just reminding everyone that that's a really great resource. And that's basically right beside that resource, the next page in the book. And we get lots of phone calls at the PHU about where people can get their COVID vaccine. Not all providers have all vaccines. So if you just Google find a clinic, this will pop up from Health Direct, and you can literally put in your district and it will pop up all the providers in your postcode.
And as nurse immunisations, like how many people contact you about where do I get my COVID vaccine from? Yeah, well, I just use that all the time. So at work and out of work. Yeah.
Yeah, and that's it. Every single person in the population can access that just by Googling find your clinic. I think, Nick, you had this up as well. It's just a really easy chart. I've got a laminated copy of that down the back of the room as well, just because there's so much variation in our COVID-19 vaccines, who gets what and when, and who's eligible for doses. It's actually a two-sided document Oh, I haven't got the other side. Sorry. But I do down there. So it's just an easy one-pager that you can have with yourselves in your clinics just to help you make that decision on who's eligible for what and when to give it. So that's the slides from up there. And so now we'll go into our Q&A. So I think we're going to have Nick, Wendy, Alice, Kim, myself. So if you've got any questions, we'll have some roaming mics. We've got Slido, and yeah, so I think this is probably the last session of the day. So if you've got any burning questions, don't hesitate. If we can't answer them, we'll email answers back to you. You know, everything's an option. So I've got the Slido here if you want to read any of the questions, Nick.
Do you want me to read the questions? I can do mine.
There's lots and lots of them.
Some of them will be answered, I think.
But anyway, is there anyone in the room with a burning question for someone on the panel?
Do you want me to start these sliders? Yep. Okay. So how do tetanus boosters given in ED get put on air and Boostrix for 28-week pregnant women?
Okay, I can help with that one. As Kim alluded, private practice have a lovely automatic system, and our CHOC or eHealth system isn't quite that advanced, but a lovely air integration program is getting developed. So all of the vaccines that would be administered in a hospital setting will automatically go up to air. So at the moment it's a manual process. So those nurse immunisers working in a hospital space with access to air can manually upload, or we do help people with that. So,
because I think a lot of nurses working in ED wouldn't have access. No.
Not all of them, yeah. So there's a little person in the audience today that got the delightful news today that we've just helped put their last 3 months of doses on. So don't hesitate to reach out if you've got some vaccines that you need uploaded.
Yeah, Boostrix for pregnant women. Who, because I think doctors' surgeries would be doing, is this like something at maternity hospitals? Yeah. I know a lot of the midwives in Dubbo have been asking for PROTA access. So if you wanted to email our team, we can give you PROTA access so you can, but I mean, it's only going to be a short time and then hopefully we're going to it's going to go straight to, but I wouldn't hold our breath. Health doesn't move too fast. So if you want PROTA access, yeah, reach out to us and you can get it and you'll be able to put it on. Because really, as nurse immunisers, Annies, you should be putting all your vaccines on air.
That's okay for us immunisers, but there's an awful lot of nurses in midwifery and ED that RNs give it, and they're not immunisers. So that then falls back onto the poor immunisers that they have to upload it for their whole unit, and that's really a massive workload.
Yes, and it's going to be great when it all goes like that, yeah.
And that's it. That's why we've just assisted one of the A&E departments by putting them all on.
I'm just going to add that it's a bit of one of the problems is that I wanted air to have, when you enter Boostrix, to have Boostrix pregnancy, because we can't really tell you what the uptake or the coverage for Boostrix during pregnancy is. They're not doing that because I think they thought that people would make mistakes when entering it. So we do have that gap in, like if you said to me, what's the flu uptake and Boostrix uptake like for pregnant women? We don't really have great data on that at a national level, at least. We might have it on locally, but not nationally.
Why is Pneumovax 23 so restricted when people with a chronic disease are to have a second dose? I'm only allowed to order one a month.
Nick, do you want to answer that one?
I don't know about the ordering part of it.
Yeah, that's and yeah, there's definitely a shortage. I think more so than anything. So yeah, if you need more doses than what you can actually get from your ordering, just let me know, and we can certainly advocate for more doses at busy clinics from the vaccine centre.
If under 70 and wanted the shingles vaccination, what would you advise?
Do you want to do that one?
I suppose if they're Aboriginal and Torres Strait Islander 50 and above, yes. I suppose it's how close are they to 70? If they're just about to turn 70, get the funded free vaccine because it's a cost. But if they're, low 60s and they're someone they know has had a bad episode of shingles and they really want to protect themselves, then yes, you can get it, but you just have to pay for it. Yeah.
Thank you. Free the 5 to 15-year-old flu vaccine gap. Can we give them in community health vaccine clinics? Schedule says 6 months to 5 years. Well, I can answer that one. Unfortunately, you can't. So if you're working in a government community health centre, we're ordering vaccines. We can only order vaccines on the NIP, and that's for the 6 months to under 5. Pregnant women, only the people that are eligible on the NIP. Is there somewhere we need to record the slushy test results if it could be later looked at in an audit? Well, yes, on your audit there is a place that says, have you done the slush test and the date that you've done it. So, and that's all in the Strive for 5 handbook, the Bible. What NIP vaccines and age groups can pharmacists now vaccinate? What course do they need to undertake, and how much is the out-of-pocket service charge?
That list is growing rapidly, actually. The pharmacy program has expanded, and for me to rattle them off the top of my head is quite a difficult task right now, but if you can actually Google pharmacy...
Yeah, I Googled it the other day, and it's on New South Wales Health. Yeah, and they have the big
I've got
list.
the details in my bag over there if anyone wanted to
I've got
come
it
and
at
have a
my
look at the
desk
list.
at work.
Do you want to talk specifically to anything, Nick?
No, like you said, I don't know the specifics, but I know it's expanding, and certainly for adults, there's obviously flu. I think Boostrix is part of it. I think MMR might also be part of it.
And some
COVID.
of the school program vaccines.
Yeah.
I think it's over 5 years as well. So nothing under 5 at the chemist or pharmacist. But it's definitely an expanding space. So watch this space because they're definitely becoming a large provider.
And I don't know about the service charge. Like I think some... Do you know?
I actually asked that question. I wanted to know because I had conflicting things I've heard. Our local pharmacy, as far as I knew, was giving flu from 5 and up, and then I heard someone else couldn't get it at another pharmacy for their child. So that's why I was trying to find out.
Yeah.
So we're giving the same advice.
I
know at our pharmacy, in Molong, it's a $15 service fee for NIP-funded vaccines, and then $25 for, flu.
Yeah, because I know I had an Indigenous couple, and they were wanting to know where they could get the flu vaccine, and and I said, chemists, GPs, and they said, but they had to pay like this service fee at the chemist, and I sort of went, well, that's not good. That's not really encouraging people to get it.
But and that's it. They're covering their costs, so they've got to pay for their staff and bits and pieces, I suppose, is the argument that we've been told.
I don't know. My sister-in-law's a pharmacist. I wish she was here, but I don't know the money side of things. I know they get money for COVID vaccines, and that's why that's... you should never have to pay for a COVID vaccine at the moment at the pharmacy. Yeah. Michelle's done something. I think she's already downloaded that pharmacy. So that's going to go on the email, Michelle? Or someone's downloaded something on here. Gosh.
Thank you.
Well, this is to Nick Wood. What's the deal with the long-term flu vaccine? How long before it's out and how long between each dose?
So this is the holy grail of vaccinology for the flu, in that we give you one vaccine that lasts forever. And the concept is that there's a common part of the flu virus that is in every flu, flu A, flu B, from now and into the future, that common protein or that common bit, that your body can recognise that when it's in a vaccine, you make antibody, and that antibody lasts for years. so we don't have to keep vaccinating every year. A bit like MMR, you know, we give them measles, mumps, rubella, 2 doses, and that's pretty much it for life. I think it's still a good 5 years away, to be honest, because what the study would have to do is get people to have this common protein flu vaccine, if you like, not have the other one, and they get followed for a couple of years to see how long protection lasts. So I think there was something on the news yesterday about a trial in Queensland, but it's still a few years away is my thinking. The people have been looking at it for about a decade and haven't quite cracked it yet. And the same thing would happen with COVID. They'd probably like to find a bit of the COVID, the SARS-CoV-2 virus that is common, that is across all of the variants, that we make antibody and cellular immunity to, and that lasts for years. Not there yet. And then they put it in a tablet and you just drink it.
Wouldn't that be great? Can we do anything about giving Bexzero to non-Aboriginal and Torres Strait Islander when parents come with script for Bexzero at hospital clinics? Unfortunately, you're not covered. Like as a nurse, and correct me if I'm wrong, Belinda, as a Annie, an authorised nurse immuniser, you're only really allowed to give vaccines that are on the NIP. So if a GP's given someone a script,
It should be given in a GP.
it should be given in, like that GP should give it. And a lot of people ask me that question, and I just think you're just not covered. Like, so if something went wrong, you're actually not covered to give it. Yeah, I mean, if you've got an agreement in your area, like if that's, like, and your manager's happy with that, yeah, because where I work is in a community health centre. We don't have any doctors, like there's no one, and we definitely don't do that there, yeah. And I worry about the cold chain too. Like, you know, they've got the script, they bring it in, could have been in the car for 10 hours. Like, you know, where do we get covered for that? Yeah. Yes? Yeah.
We still get it out of our fridge, but they're still happy to pay for it, but they don't have to go to 2 separate appointments to get needles. Like, is that something we can look at in the future?
Hello, lovely Stacey. Oh, I'm seeing all these lovely nurses, I know. I can't see it happening because, like, you know, we do that course when any, and, you know, we can do what's on the NIP and that's it. But they're like, so the doctors prescribed it, they feel it, and they've come then to a government facility, like our community health centre, for us to give it. Yeah.
I take your point about.
I can see the frustration, especially if you live in a town where there's, you know, they mightn't even have a nurse working at the GP. Is that what happens, Stacey? Like, there's no one to give it at the GPs?
Have to drag kids to, more or less.
Yeah.
Yeah.
Yeah. I can feel your frustration because, you know, parents want the best for their kids, but Dubbo's a lot bigger than your little centres, but what they normally do is they just get those vaccines done at the GP because they can get it all done at once, which is easier said, but when you're in small communities, that can be quite hard. And I've worked in small communities.
How are we going with Slido?
Why is Boostrix not funded in EDs instead of ADT? And ADTs are. I think we've had that question a few times over the years.
It's not funded, but I don't know why it's not funded, to be honest. I do. You do? There you go.
It's a cost factor. No, it is. Because I've heard,
right.
yeah, it's so, and a diphtheria, tetanus, whooping cough is so much cheaper than the diphtheria, tetanus. It's all about money.
Unfortunately, it is. And, you know, it's the same argument. Why is there only 1 varicella on the NIP, not 2, when the recommended says 2? It all comes down to the dollar. So if, it's unfortunate.
It comes down to, because if you have 1 varicella vaccine, that prevents you from severe disease and getting really sick. And so the government's just prepared to fund the 1. Yeah.
Correct. Any other questions from the floor? Oh, thank you. Just there.
I work on the school-based immunisation program, and recently
somebody had attended the clinic, year 7, and had had an ADT in emergency 3 weeks prior to the clinic. So I didn't want to give a Boostrix. What is the gap recommended between 2 tetanus doses?
1 month?
Yeah, I mean,
Kendal. Yes. So, yes. Yes. So Kendal was just saying 1 month between 2 tetanus-containing vaccines.
But they might get a sore arm. Yeah. So minimum of a month probably would be. Yeah. And you're really only going to give them the extra bit as the pertussis boost. So. Yeah.
If you're going to get a booster dose number 3 for COVID, would you recommend changing brands from Pfizer to Moderna bivalent?
Probably not, to be honest. I think a usual rule, if you've had Pfizer the whole way, stick with that and continue the course in that one. I don't think there's anything out there to suggest that the mix and match schedule. There were a lot of studies looking at AstraZeneca matched with, different platforms, because the AstraZeneca was an adenoviral vector and the Novavax one is a protein-based one, and then Pfizer and Moderna are mRNA. So people are looking at mixing and matching that sort of platforms, but in terms of the mRNA ones, I don't think there's much added benefit to go from Pfizer for a few and then Moderna for the others. But if it's all you've got, it's okay to do, but it wouldn't be something you'd recommend.
Thank you. What's next?
I can answer this one. Can children under 12 months receive an early measles vaccine if travelling to endemic country prior to 12 months of age? And that's all in the handbook. So from 6 months of age, you can, and they call it an extra MMR vaccine. So you still record it on air, but it's actually an extra one. So you can give that from 6 months of age onwards. But then they still have to have the MMR at 12 months and 18 months, or the MMR containing vaccine, as usual. Yeah. Actually, when you're doing catch-up vaccines, and this is all in the handbook too, if it's after their 11th month of age and they've received an MMR vaccine, AIR will record that as a valid dose, but they must be after 11 months of age. They can't be 10 months and 29 days, they have to be after 11 months. But that's all in the handbook.
Perfect.
Vaccilis, did I pronounce that right? Vaccilis and Hexa interchangeable.
So it'll probably come out when the guidance comes out, but again, if you start with Hexa, try and finish with Hexa. Start with Vaccilis, finish with Vaccilis. If you are not in that position because of whatever position you're in, you can swap them. But it's again not recommended to do. So there'll be some line probably in the handbook or the guidance that says, in the event that you cannot complete with one vaccine, it is okay to use the other one to complete the schedule. But that's not formally announced yet, but it'll be something like that.
Thank you. The questions keep coming on Slido. Is there any more questions from the floor that anyone's brave enough to speak up? Nope. When will the New South Wales Authorised Nurse Immuniser qualification be nationally recognised? I have no idea. Does Nick have any idea? No? PHN?
Someone's got a...
Yeah, you can actually Google NESA for the qualifications that are recognised.
Thanks, Bill. I actually asked that question because I've been doing some work in the Northern Territory last year and they do not recognise the New South Wales qualification. You'd have to go and do the South Australian course.
Well, isn't that wonderful that that's the one that I'm doing scholarships for?
That's good.
Thank you,
I hope it's multiple choice.
There was a thing released earlier this year that actually did list all the states and which courses were recognised by the individual states.
I think that's that NESA website.
And if it was done through the College of Nursing, our course is approved. If you do it through any of the other ones, some states recognise other trainers, others don't. So that was only earlier this year.
Thanks, Kim. And that's exactly it. They're broadening what they accept. So, you know, it would be lovely to see a national recognition. So let's hope that, yeah, they're going to broaden that and make that a reality.
This one, the QR code for the evaluation won't work for me. Is there another way to complete the evaluation? Michelle?
That's a PHN question.
Maybe go and see them at the end. Yeah.
It's been posted as an answer to that Slido, and we will also email it around.
Will the Bexero vaccine become available on the NIP for general population?
I don't know. It sort of, to get onto the NIP, remember it has to go through PBAC. It's been to PBAC a couple of times, not quite got the cost-benefit assessment. So I suspect they'll go back again, but not that I don't think it's there just yet. But yeah.
Again, it's probably that dollar and cents.
Yeah.
I've had some healthcare workers tell me, I'm a staff health nurse, that they were told that healthcare workers can get another flu vax towards the end of the season.
I was going to say, is there a reason why? Were they travelling? Because that would probably be the main reason to receive a second 2023 flu vax. But otherwise, a single dose is sufficient.
Adverse events of COVID vaccines. What time frame post-vaccine would you consider pericarditis or myocarditis be reported as an AFI?
It's a good question. So the usual onset is within the sort of first week that you would experience chest pain, palpitation, shortness of breath sort of thing. I suppose if you last had a COVID vaccine 6 months ago and then all of a sudden you got pericarditis, I probably wouldn't be thinking that's a vaccine. But if, however, it was a month after, probably would. But there's no magic number. I think if as long as when you put the report in, you've got the date of the vaccine and the date of the symptom onset, because often what happens is people, they might come to you or the GP, whoever, and say, oh, I've had chest pain and palpitation, but they've actually had it for several weeks. They've just been ignoring it. So the true onset might have been closer to the vaccine, but the actual diagnosis was made a month later, if that makes sense. So that's the sort of thing you need to tease out a bit. But in general, if there was no problems at all, and it's been, usually we say sort of 6 weeks after the vaccine, most things happen in the first 6 weeks. If it's after that time and it's a new condition, may not need to report it, but you can if you're worried about it, or particularly if the person wants you to report it.
Airlocks. Why do some vaccines have a larger airlock than others? And immunisations you draw up, what kind of airlock volume should you accommodate for?
That's a good question. And that's it. You know, your flu vaccines and stuff like that, where you just literally pop the rubber bung off the top, you don't dispel the air from those vaccines. You just give the vaccine. So I think, yeah, if a manufacturer has left an airlock, you leave that airlock right where it is. As far as if you've reconstituted a vaccine and, you know, you wouldn't leave an airlock. You would just, remove all the air from the syringe before administration. So I hope that answers the question. Send me an email if you want more detail.
I think it's in the handbook. Last year there was a discussion about trialling Q fever vaccine in children. Has there been any advances in this age group?
I was hoping you wouldn't ask that. Slow progress. So we got COVIDed in a sense. We wanted to ramp it up, and then COVID came along, which meant we couldn't get out to the country to do it. So we are attempting to get to Hunter, New England area later this year. I think one of the problems for a lot of the vaccine trials at the moment is general vaccine fatigue in the community. I don't know if you guys are seeing that with the routine vaccines, but people are, oh, no, not another vaccine. So we are hoping to get to Hunter, New England, Tamworth, Armidale, and I think Scone in the last quarter of the year to do it, the program. But yeah, not much progress because of COVID, unfortunately.
It'll be very popular when it becomes available, I think, Nick. There's a lot of farming families, agricultural kids that, would like their Q fever vaccine much earlier in life.
If someone with chronic conditions has previously had pneumothorax, Pneumovax, when should they have Prevnar and then the second dose of Pneumovax?
Yeah, so I think we're saying at least a year after their Pneumovax, get the Prevnar, and then again more than 12, I probably would say, I think they say 2 to 12 months, isn't it, after the... Here we go, here's something we prepared earlier. Can you read that? So it tells you the reverse, but if they've had Pneumovax, and then I would probably wait maybe 12 months, depending on their age, to give a Prevnar 13, and then the next Pneumovax would be somewhere along the lines of 2 to 12 months, but again, I think you could wait 12 months, as long as the gap between the two Pneumovaxes is 5 years.
Yes.
Yep. That's...
This one's for Nick. Nick, should you have a tetanus booster in between DTPA doses?
No, I think just I would use DTPA or the Boostrix. Remember the Boostrix is the lower dose version of Influenza, so it's got less D and less P, less pertussis in it. I would just use that as your tetanus booster. You get the added benefit of the pertussis boost. So don't think there's a need to have a tetanus. I'd just be using DTP as my tetanus booster, Boostrix. Yeah.
This is a good one because we used to ask this all the time. Where does the money from vaccines given in community health go?
Into a slush fund. I get asked this question a lot. Once upon a time, historically, these funds went straight back to, the childcare centre or that small MPS that might have a childcare centre. And I'm not sure when it got flipped over, but it basically just goes into revenue. One consolidated account in revenue. Revenue or finance can't pull out, $100 from that clinic because that's what you got from your occasions of service. So I don't have full access to that either, but it's definitely what pays for things like scholarships, assisting in the funding of conferences like this. So, yeah, it is unfortunate, but I think, we used to use that funding to help with the purchase of new fridges, et cetera, especially in our small MPS sites. But I don't have that access as much either, but if you need a new fridge, let me know. But I do advocate that you go to your immediate manager first before coming to me to get a new fridge because, access to those funds isn't as easy as it used to be, and unfortunately New South Wales Health have put it into one revenue fund and it gets absorbed into other spending environments. So it's not the way it used to be.
This one's from a desperate mum. Giving Bexzero to a kid that you can't get Panadol into oral or suppository, what would you do?
Suppository even? What would I do? I mean, the purpose of the paracetamol is purely for comfort. So they may not even get a fever. I think if you've tried all the ways you can, it's not an absolute failure if you don't get the paracetamol. It's purely comfort control, to be honest. That there was a concern that particularly the 6 month and older age group who might get a high fever might have a febrile seizure. So that's the idea, to control the fever a bit. But I don't, if you can't get it in, that's not a major loss. They might just be a bit uncomfortable. Maybe if they do have a fever, they might then take the Panadol, treat it when they get it. And then there are other measures to, treat fever, that you often do that are non-medication based. So when they brought in this concept to look at paracetamol pre and post vaccines, there was concerns that the paracetamol might impact the immune response. So they actually looked at that in the vaccine trial. They gave half the kids with Panadol and half the kids without Panadol, and then looked at their antibody responses, and there was no difference. So I wouldn't worry too much if they don't get the paracetamol, if that makes sense.
How are we going, Kim? We've got a few more questions on Slido. Is anyone from the floor got a question? No? Let's continue with the Slido.
Why do children's catch-up schedules using their calculator differ to what AIR lists as due, overdue? I think I can answer that. Sometimes PRODA, the provider of digital access, has glitches. Has anyone noticed that? Sometimes, you've put all these, I know myself, sometimes I put MMR in, you put it in twice, it's at the right time and whatever, then it still says that they need an MMR, and then you go in and then you can flip on the side and do some, and they say, oh, it's pending or code or there's something happening. So I think AIR is not perfect and often there's glitches. So sometimes I actually then go and email them and go, hey, you're still saying, and put the details in and say, it's still saying this child needs another MMR, but they don't. They've had 2 doses. They've had them a month apart. They've had them after 12 months. And then they eventually fix it. Has everyone had experience with that? Yeah. So I think that's why it differs. Sometimes there's some glitches.
Good answer. We've got a question at the front. I'll bring the microphone to you.
I've got a really good question. Someone said lucky door prize. Hell yes. When's that happening? Oh, okay, cool.
Sorry, I'll be quick then.
No, I didn't get a ticket, but anything's exciting.
Sorry, one of the problems I've had with uploading overseas childhood vaccination records onto AIR is that it likes to squish everybody into that 2, 4, 6 month and then 12-month kind of category. And so that's really tricky, particularly some of the Indian records, they do 10, 14 weeks. And so then AIR puts it through because I've had it at 10 and 14 weeks, it puts through 2 shots of Hep B and then calls it a duplicate, and you've got to ring and say it's not a duplicate, it's 4 weeks apart.
Do you need to wait on the phone a long time? Because I've given up on the phone. I just email them now.
It's tricky. And I wonder if there's anything that they could do in order to, if you click that you're doing an overseas record, that it kind of scraps the whole idea of trying to fit it into our little Australian batch.
I just put it all in as others.
Yeah.
I do too. Oh, you do too? And then they still do that. But then
they still try and push it into that 2, 4, 6 month category, and then you end up with duplicates in say the 4 month. If they've had a 10 and 14 week vaccination, it'll put 2 in at 4 months, and then it will still tell you that it's due another one, even though it's not, because it's counted those 2 as 1 dose. So if they could find a way to make overseas vaccination where you just put it in and they just accept it for what it is rather than trying to squish it into those categories.
That's why sometimes when that gets a real headache and you're ready to top yourself, that immunisation history form's good, that you can just fill it all out and then upload it.
On the printout, it would be really helpful for them for it not to be in those categories.
Yeah, it's very frustrating. But remember, it's a government thing.
Well, Lauren Dalton, who many of you may or may not know, she works with us in the PHN program. She has very close links to the AIR team. So we can take that back as a suggestion to them to think about exactly as you said. Yeah.
Sorry, just with
it's like the overseas people need another page, another, yeah.
Just on that, with that AIR form you were mentioning, is it a different form? Because I was always told that's being phased out and not to send it, and I've had it rejected from Medicare.
I wonder if you've got the new one, because I actually went on the website today, because you can actually upload forms and they still have that even the number of the form that you can upload that. Yeah. Yeah.
Any more questions?
Use it quite a bit, so maybe next time just give me a call and we'll work through it. Yeah. Because the form has been updated. There has been old forms, so I wonder if it was an old form that was used, yeah.
How are we travelling? Everyone want to get out of here? Okay, let's wind this up. Is there any more burning questions on Slido?
Okay, I think it is. I think the silence has spoken for itself. Lucky door prize time. There are 3 potential winners, okay? So if you would have been given upon entry, I hope, a magic number on a ticket. Nick's going to do the honours of holding the box for me. I'm not going to look. Dip number 1. Drum roll. There we go. Oh, geez, that's good. I like that. Blue. 62. Do I have any takers? Here we go. Come forward, please. Congratulations. Yes, blue 62. Well played. Tip number 2. Another blue. It's not my fault. 76, the year of my birth. Not that that's a secret. No blue, 76. A, 76. Going once, going twice. Redraw. Aha. Okay, this one is orange, red, sorry. B, 73. Well, mine says red, so if... Okay, well, if you've got... Bring it up. 73. If it says B, 73, I'll take it. We have a winner. That's yours. Well played. Yes, vermilion, orange, burnt orange. Okay, here we go. Final dip. Another burnt orange. B23. Lucky last. Who is it? Don't be shy. Up the back, here we go. Well played. Well, that brings to a close the draw and, of course, to our wonderful event today. So, look, before you do escape, just a quick reminder on evaluation. Now, I've been told for those that have older generation phones that can't read that QR code that was on the one pager, you can, within the Slido, there was a link advertised that you can access the feedback. So it is important, so please complete to receive a certificate of attendance, which we know is a big bonus. So look, thanks for attending the conference today. Thank you for being such a great crowd. I would like to, before we do wrap up, thank the speakers. Round of applause, please. Last but not least, of course, to the Western New South Wales Primary Health Network staff behind the scenes, Michelle Drulis, Katie Pryor, Erica, the list goes on. I have to say, awesome, thank you. Travel safely, everyone. Till next time.